Okay, fine. So, good afternoon, everyone, and a very warm welcome to all of you from Study MRCOG and Study Medic. Today is day 7 of your rapid revision marathon, and I hope all of you are enjoying this program as much as we and the mentors we are enjoying. Quick revision of all the modules with all of you. So today we have early pregnancy and postpartum. Let us begin before wasting any more time. A lot of topics. We have around 10 topics to cover today. Miscarriage, ectopic, recurrent pregnancy, gestational trophoblastic disease, hyperemesis, pregnancy of unknown origin, abortion care, uterine perforation, maternal sepsis, postnatal mental health, postpartum hemorrhage, postpartum collapse, and routine postnatal care. So early pregnancy and postpartum. And then at the end, we will solve some important questions. In the middle also, as we are going through the topics, we will be solving some important questions. Okay. So miscarriage, ectopic, maternal sepsis, especially gas infections, postnatal mental health and psychosis, postpartum psychosis, and management of PPH. You will get a lot of questions from these topics in the exam. These are the most covered ones in the exam. Then recurrent miscarriage, antiphospholipid syndrome, gestational trophoblastic disease, FIGO scoring to calculate the type of chemotherapy you want to give, hyperemesis, calculation of the Puke score, abortion act clauses, and postpartum collapse and amniotic fluid embolism. These also would be there. And in order to, answer all these questions, you need to have a very good understanding of how to diagnose pregnancy of unknown location. How do you calculate what is the level in HCG rise or decrease? About uterine perforation sites, different types of ectopics, that is especially cesarean scar and abdominal ectopic. What is the routine and postpartum care? And how do you decide the antiemetics that are to be given for women with hyperemesis gravidarum? It means which is the first line, which is second line, and which is third line. Okay. So let us start with miscarriage. For this, you have the NICE guideline 126, in which you have ectopic and miscarriage. Before we start, you should be able to diagnose what is the type of miscarriage. So, what is the definition? Okay, like the clinical picture, how you are going to match it with the type of miscarriage. So, any woman who presents with the viable intrauterine pregnancy on ultrasound with an os closed and who comes with minimal amount of PV bleeding and sometimes abdominal pain, it is called as a threatened abortion. Whereas it is inevitable, or like the abortion is going to happen now. Whenever you have a pregnant lady presenting with bleeding, and on examination, you see that the os is open and you can see products visible at the os. Incomplete abortion is where she gives history, or you can see signs of the products of conception having passed away. There is some retained tissue in the uterus. There is bleeding, minimal or profuse bleeding, and plus the os is also open. Whereas on the other hand, it is missed or silent or delayed miscarriage when the woman, she has no symptoms, or she might sometimes present with minimal bleeding or altered discharge. And on ultrasound, you see that there is a sac. You could even see the fetal pole, but there is no fetal cardiac activity, or sometimes you might just see an empty sac and no fetal pole. Complete abortion means she gives you history that she has passed some clots either at home or in the hospital, wherever it is. All the products of conception have been passed. The uterine cavity is now empty. On ultrasound, you see a very small or an empty uterus and the os is closed. So that is your complete abortion. Now, septic is whenever some retained, the uterine cavity is infected, and there are retained products, or there might not be any retained products in the uterus. But very important signs of sepsis are there. That means there is fever, there is uterine tenderness, and offensive vaginal discharges there. So early miscarriage is the one that happens in the first trimester. That is less than 12 plus 6 weeks of gestation. It is early miscarriage. And when the loss is after 13 weeks, but before 23 plus 6 weeks, then it is called as a late miscarriage. Now, the new guideline from RCOG on recurrent pregnancy loss, it defines recurrent miscarriages as more than or equal to 3 losses. The most important thing to remember here is that the losses might be consecutive or non-consecutive. Previously, we were always taught that it is 3 consecutive losses, only then you will call it as recurrent pregnancy loss. But according to the new guideline, it could either be consecutive or non-consecutive losses. Now, as we have seen the definitions, any pregnant woman that is seen by you at any point of time, let us see what is the referral pathway for this woman, pain or bleeding in early pregnancy. So any woman presenting with pain or bleeding with a positive urine pregnancy test, there are 3 scenarios or 2 scenarios that could happen. First, most important thing, you have to see whether there is pelvic tenderness, there is cervical motion tenderness, or there is abdominal tenderness, or you are having signs and symptoms of intra-abdominal bleed. If there is the signs and symptoms of intra-abdominal bleed, remember it is a very high-risk patient, most likely to be an ectopic. Okay, so you will immediately refer her to the higher center for investigations without wasting any time. Now, if there is no cervical motion tenderness, there is no abdominal tenderness, patient is relatively stable, then you will see about the period of gestation. Okay, so if the period of gestation is more than or equal to 6 weeks, or she is not certain, like her cycles are irregular, or pain, if there is pain. So any woman like this, you will refer her to the early pregnancy assessment services. Now it depends. If the pain is very severe, even out of hours, you will refer her to the early pregnancy assessment service. If the pain is only mild, you can send her during daytime. Now, if the pregnancy is less than 6 weeks and the woman, she doesn't have pain or there is no bleeding at all, then it is unlikely to be an ectopic or it is unlikely to be like severe hemorrhage. So you can offer her expectant management because slight bleeding in early pregnancy is common, and especially if it is not associated with pain or anything, you don't have to be very much concerned. So you will just offer her expectant management and you can call her back for a repeat UPT in 7 to 10 days time. But you have to counsel her that if the symptoms become more severe, or if the pain persists for a long time, or if the bleeding also persists, then she has to come back immediately. So this is how we are going to triage the women, those who present in early pregnancy with pain or bleeding. One thing that you have to remember, that whenever there is cervical motion tenderness or there is pelvic tenderness, it is a red flag sign and you should not ignore these women, and you will immediately refer them to the higher centers for exclusion of an ectopic pregnancy. Now coming to the ultrasound criteria, like how will you decide whether this pregnancy is a viable pregnancy or it's a non-viable pregnancy? So if you are doing a transvaginal scan, okay, remember this, we are talking about a transvaginal scan. If you see a CRL that is there, and the CRL is less than 7 millimeters and there is no fetal heart, don't immediately say that this is a non-viable pregnancy, because the threshold is 7 millimeters and here the CRL is less than 7 millimeters. So for this woman, CRL less than 7 millimeters, no fetal heart seen, offer her an appointment or offer her a scan after 7 days before you come to a diagnosis. Remember, we are doing a transvaginal scan. If you are doing transabdominal, the scan should be repeated after 14 days. Now, if you see this woman with a CRL more than or equal to 7 millimeters and there is no fetal heart, Okay. Even here, don't rush in and say that this is a non-viable pregnancy. Always get second opinion, like a second person should be doing the scan, or you can offer her scan after 7 days before labeling it as a non-viable pregnancy. Now, if you are not able to see the fetal CRL, or if you're not able to see the fetal heart, but you can see only the gestational sac. So on transvaginal scanning, if the mean sac diameter is less than 25 millimeters and there is no fetal pole, okay, only this empty sac is seen. Even then, don't say that this pregnancy is non-viable, or don't label it as an empty sac immediately. Call her for a scan after 7 days. Now, if you see the mean sac diameter is more than or equal to 25 millimeters and still there is no fetal pole, get the opinion from a second person, get a second opinion, or offer her a scan after 7 days. And only after the second scan is done, then you will label her as either a non-viable pregnancy, or maybe at the second scan, you are able to see a fetal pole. So give your diagnosis only after the second scan. Now remember, when you are doing only transabdominal, okay, and you don't see a fetal pole, you do not see a fetal heart, the rule is always, whenever you are doing a transabdominal scan, the repeat scanning should always be done after 14 days. When you are doing transvaginal, it should be after 7 days. Okay. Now, if while doing a scan, you see that the heartbeat is visible, then you can say that this is a viable intrauterine pregnancy, and you can send her for a routine antenatal care. Whenever you see a subchorionic hematoma, remember that most of these subchorionic hematomas, they resolve. Okay, so you can counsel the woman about the ultrasound findings, and you can repeat a scan. If you're doing TVS, repeat after 7 days. If you're doing transabdominal, repeat after 14 days. Though on a transabdominal scan, it's really difficult to see a subchorionic hemorrhage. Two things that you have to always keep in mind without fail. You will never diagnose miscarriage on a single scan if CRL is less than 7 millimeters or mean sac diameter is less than 25 millimeters. You will always offer a repeat scan after 7 days. And whenever you are at the threshold, always get a second opinion. Now, supposing you have diagnosed a miscarriage, so how are you going to manage? Remember, in UK, always it will be some management will always be expectant or conservative, then least invasive, and then invasive or surgery is the last resort that is usually offered. So, like that also, similarly, for miscarriage, first line of management is expectant. And at the end of this expectant management, UPT is always offered at 3 weeks to know whether the miscarriage has been complete or not complete. So this expectant management you will offer for 7 to 14 days. But keep in mind that any woman who has a increased risk of hemorrhage, like she is a late first trimester, someone who is at about 12 weeks of pregnancy, she can have increased risk of hemorrhage. Or there has been a previous traumatic experience to this woman. She has had a previous stillbirth. She has had antepartum hemorrhage in the previous pregnancy. She is someone at a risk of, she has a coagulopathy, or someone at a risk of infection. Always better to avoid expectant line of management for these kind of patients. Now, the other thing is they are going to be having some amount of pain. So you can give paracetamol and NSAIDs for pain relief. Now, 7 to 14 days after the time has, at the end of 14 days, if the woman comes back and she says that now there is no pain and there is no bleeding also, you will offer her a urine pregnancy test at 3 weeks. Now, if at the end of 14 days she still says that the bleeding is there or the pain is there, or she has passed out only some products of conception, you will do a scan to see whether it is an incomplete abortion. If for this woman for whom the pain and bleeding, everything is resolved, and she comes to you with a urine pregnancy test at 3 weeks. Now, if the urine pregnancy test is negative, be assured that the pregnancy or the miscarriage is complete and she is away from discharge. You will discharge her. But if the urine pregnancy test is still positive at the end of 3 weeks, then you have to be on the lookout that it could either be a molar pregnancy or it could be an ectopic. So you will have to send her for a clinical review. Now, if the expectant management fails or it is incomplete, you can offer continued expectant management for a period of more than 14 days. Or if the woman, she doesn't want to continue expectant management, you can offer her medical or surgical management. And it's very important to counsel these women that when they are undergoing this expectant line of management, they are going to have some amount of bleeding. This bleeding that they have, it is heavier than the normal period that they have. They could be having pain in the form of cramps. They are going to pass out some amount of tissue. And if they feel that the bleeding that they have is very heavy or she experiences dizziness or any other symptoms, then you have to provide them 24/7 contact numbers where they can come and contact, okay, in case of heavy bleeding. Now coming to the medical management of miscarriage. So two drugs are now there, mifepristone and misoprostol. So mifepristone is the one that is there in the new guideline. Previously, mifepristone was not used. So you will first give mifepristone 200 milligrams per oral, that means orally. And then 48 hours later, misoprostol can be given. It can be given vaginal, oral, or sublingual. Whereas for incomplete miscarriage, remember, no mifepristone is used. It is only misoprostol. So misoprostol 600 micrograms and a single dose can be given vaginal, oral, or sublingual. Now remember, the guideline also says that to make it easier to remember, you can also give misoprostol 800 so that both the guidelines are similar to each other. So for missed miscarriage, mifepristone 200 plus misoprostol 800, or you can give misoprostol 600 or 800. Both the options are correct. Okay. If required, antiemetics and pain relief can be given in the form of NSAIDs or paracetamol. Now, any woman, after she has received misoprostol, it is expected that she starts abdominal pain and bleeding within a period of 48 hours. If after 48 hours, the woman reports that there is no bleeding, then she has to be subjected to a clinical review. Similar to the expectant management, UPT is done after 3 weeks, and then the rules are the same for discharge or for a clinical review. Now, during treatment, at any time, the woman thinks that her symptoms are worsening. That means there is heavy bleeding or she has too much of pain she cannot tolerate. She will come back for a clinical review. Medical management is offered routinely for most of the patients, except if you are suspecting an ectopic pregnancy, okay, or the ultrasound picture or something is suspicious of a molar pregnancy. In these two cases, you will never offer medical management. Also, chronic adrenal failure, mifepristone and misoprostol both are contraindicated. Severe asthma is a relative contraindication for misoprostol. It is not a strong contraindication, relative contraindication. So remember, for miscarriage, mifepristone and misoprostol both are to be given, whereas for incomplete miscarriage, it is only misoprostol. No need of mifepristone for incomplete miscarriage. Now coming to the surgical management. So manual vacuum aspiration is done usually for missed miscarriage. And this is an OPD based procedure, no need for indoor admission. The plastic cannula that is there, it is latex free. Volume of the cannula of the syringe is 60 ml. The vacuum that is created is between 610 to 660 millimeters of mercury. The length of the cannula is 24 centimeters, and you have cannula from size 4 to 12 millimeters, and they are color coded. No need to remember the colors, but remember that number 4 cannula, number 6, they're usually 4, 6, 8, 10, and 12 number cannulas. All of them have different colors. Now, what are the criteria for whom you can offer manual vacuum aspiration? So, if it is a confirmed early fetal demise where CRL is less than or equal to 30 millimeters, or the retained products that are there in the uterus, they are less than 30 millimeters, and the pregnancy is less than 12 weeks size for a pregnancy for a late miscarriage or a second trimester, you will not offer surgical with a medical with the Carmen's cannula. Okay. Now, MVA again is not suitable if the uterine cavity is distorted. So you have fibroids distorting the uterine cavity. If the pregnancy is more than 12 weeks, or the retained products that are there inside, they are very large, or the patient is prone to panic attacks, she has anxiety, and she is someone who will not tolerate a procedure without some form of anesthesia. For them, MVA is contraindicated. For these women, then you can offer surgical evacuation under general anesthesia. So it is the surgical evacuation is standard for anyone who has failed medical management, if there is heavy bleeding, or by choice of the patient. Now, something to remember about anti-D. Remember, whenever you are doing a surgical management, okay, you will give anti-D 250 international units to a woman who is Rh negative, she is non-sensitized. And if the pregnancy is more than 12 weeks, you will give 500 international units. Now, whenever you are doing medical non-expectant management of miscarriage, at that time, anti-D is not routinely required. But the thing you have to remember again, whenever you are managing an ectopic pregnancy, you are managing a molar pregnancy, or you are doing termination of pregnancy, that means you are doing an abortion. For them, always anti-D has to be given. Okay. Antibiotic prophylaxis is given only for surgical management. So doxycycline, 100 milligrams, 2 times a day for 3 days. So this is the evidence for anti-D immunoglobulin prophylaxis. This is from the NICE guideline about miscarriage and ectopic. What does it say? That offer anti-D immunoglobulin prophylaxis at a dose of 250 international units or 50 micrograms to all rhesus negative women who have a surgical procedure to manage an ectopic pregnancy or a miscarriage. So surgical management of miscarriage or ectopic, give anti-D. Do not offer anti-D immunoglobulin prophylaxis to women who receive solely medical management for an ectopic pregnancy or a miscarriage. Those who have a threatened miscarriage, or those who have a complete miscarriage, or those who have a pregnancy of unknown location. And you will not do the Clehauer test for quantifying fetal-maternal hemorrhage. This is from the ectopic and miscarriage guideline. Abortion care guidelines have again been changed. I will put up a screenshot of that guideline later on. Okay. Now coming to a typical question. You have this 28-year-old woman who attends early pregnancy assessment services at 8 weeks of gestation with light bleeding and minor cramping for 3 days. TVS shows empty gestational sac, mean sac diameter is 22 mm, and there is no fetal pole. She is hemodynamically stable, RHD positive. What is the most appropriate management option for her? Now think about this. Mean sac diameter is less than the threshold and no fetal pole is seen. So what will you do? Expected management for 7 to 14 days with repeat UPT after 3 weeks? No, this is not definitely missed miscarriage. Mifeprostone, 200 milligrams plus miso. No. Misoprostol, 800 micrograms, single dose. Immediate surgical evacuation, not really indicated. None of these are really indicated. Why do you want to go ahead and terminate the pregnancy? She has only light bleeding and minor cramping. Rescan in a minimum of 7 days before making a diagnosis. This answer looks to be promising because you see that the mean sac diameter is less than 25. So whenever it is less than 25, you are not expected to see a fetal pore. So that is why. And since you are doing a transvaginal scan, you will call her after 7 days for a repeat scan before confirming whether it is a viable or a non-viable pregnancy. After that, then you can decide. After 7 days, whatever is the diagnosis, if the fetal heart is seen, go ahead and say that it's a normal pregnancy. If not, then you can offer her expectant management or surgical or medical management, whatever, for the miscarriage. Now, next coming to ectopic pregnancy. So, sorry, we have different types of ectopic pregnancies. The commonest is a tubal scar, as a tubal ectopic. Then you have cesarean scar pregnancies, you have cornual, cervical, ovarian, abdominal, heterotopic. All these are the types of pregnancies outside the uterus, and they are labeled as ectopic pregnancies. A few numbers that you need to know. So in UK, incidence of ectopic pregnancy is 11 per 1,000 or 1 in 90 pregnancies. And among the women attending the early pregnancy unit, about 2 to 3% are diagnosed as ectopic pregnancy. The most common ultrasound finding for an ectopic pregnancy would be an inhomogeneous or a non-cystic adnexal mass. In about 50 to 60% of women, this is the classic finding of ectopic pregnancy. And a pseudosac, which is seen intrauterine, it is seen in about 20% of ectopics. Cervical pregnancy is less than 1% of all ectopics, thankfully, because we know that it is something which is very catastrophic if you have. Then a cesarean scar pregnancy is still more rare. It is about 1 in 1,800 to 1 in 2,500 pregnancies. Cornual pregnancy, 1 in 76,000 pregnancies. Abdominal pregnancy, again very rare, about 1% of all ectopics. Another important percentage that you have to remember is that if you offer surgical management and in that you are doing a salpingotomy, the persistent trophoblastic rate is about 4 to 11%. And after someone who goes a salpingotomy, about 20% or 1 in 5 of these women, they need some further treatment for the persistent trophoblast. Now let us see what is the algorithm for a tubal ectopic pregnancy. Okay, because whenever you have a tubal pregnancy or you have an ectopic pregnancy, you have to offer some sort of management options. So for ectopics, we have 3 management options. You have surgery, you have medical management in the form of methotrexate, or you have expectant management. And let us see also what are the biochemical criteria and the clinical criteria. Based on this, you can offer your line of management. So whenever a tubal ectopic has been diagnosed, it is important to look at these things. See whether the patient, the amount of pain, whether it is significant pain or it is mild pain, the adnexal mass, the size, whether it is more than or equal to 35 millimeters, a cardiac activity, the cardiac activity is present or absent. What is the level of HCG? The critical level is 5,000, more than or equal to 5,000. And whether the lady is able to come up for follow-up or no. So, if it is yes to any of this, that means significant pain, the large adnexal mass, fetal cardiac activity seen, HCG more than 5,000, and the lady says, I cannot come back for follow-up. Don't think of any other option. Straight away, you offer her surgical management. And by default, the type of surgical option is a salpingectomy. Usually, laparoscopy is preferred wherever the services are available. And if the other tube, if the contralateral tube is found to be normal, then salpingectomy is done. If the contralateral tube is absent or there is some problem in the contralateral tube, it is damaged, then a salpingotomy is done. If the woman doesn't have any of these signs and symptoms, then to decide what is the type of management option you are going to offer her, have a look at the HCG level. Okay. So if HCG level is less than 1000 and it is falling, you can offer her expectant management. If HCG level is between 1000 to 1500, offer methotrexate as the first line management option. Okay, if the HCG level is between 1500 to 5000, you have two options here then, either methotrexate or surgery. Whereas if it is more than 5000, we already saw that surgery is the first line option. Always remember that if the HCG level is found to be rising, stop your expectant line of management. Any woman who has undergone surgical management of an ectopic pregnancy, offer her a UPT after 3 weeks after surgery. And any woman who is offered methotrexate, you will do weekly HCG until negative. So once after methotrexate has been given, day 4 and day 7, you will do HCG levels. And after that, HCG levels are done every weekly till they are negative. Now, what are the criteria for methotrexate and what is the follow-up of women? So the dose of methotrexate is 50 milligram per meter square. It is given intramuscularly. And HCG is done on day 4 and day 7. It is very important that all these criteria have to be met. Okay, there should be no significant pain. The ectopic should be unruptured. Adnexal mass should be less than 35 millimeters. There should be no fetal heart visible on ultrasound. HCG should be less than 5000. It can be between 1500 to 5000. Okay, preferably less than 1500. The patient should be able to come up for a follow-up. And on ultrasound, there should be no intrauterine pregnancy. Very important. In a heterotopic pregnancy, if you see that there is a viable intrauterine pregnancy, please do not give methotrexate. The dose we already saw, 50 milligrams per meter square intramuscular as a single dose. Important points to remember while the patient is on methotrexate. She should avoid a pregnancy for 3 months after methotrexate. When she is getting the methotrexate, she should avoid alcohol and NSAIDs because it could lead to hepatotoxicity and reduced clearance of methotrexate. Also, folic acid has to be stopped because we know that folate, it is an antagonist, like it interferes with the action of methotrexate. So folic acid has to be stopped immediately. The follow-up is HCG day 4 and day 7 and then every week until it is negative. Now, supposing you have given methotrexate, you want to know whether the response, what is the response? Is she responding satisfactorily or not? So, if the drop in HCG levels is more than 15% between day 4 and 7, then you know that your methotrexate is working. If, on the other hand, the fall is less than 15%, or you see that the HCG level is plateauing or it is rising, then you will reassess the patient, and if necessary, you can give a second dose of methotrexate, or at this point of time, you can then offer her surgery. So how to calculate what is the rate of HCG fall? Remember here, it is expected that the HCG on day 4 is higher than the HCG on day 7 because as time passes, the HCG levels are going to drop. So day 4 minus day 7 divided by day 4 HCG into 100. If this is more than 15%, then you know, more than or equal to 15%, then you know that your methotrexate is working fine and you can keep on monitoring the patient. If on the other hand it is plateauing or it is rising, you might decide for a second dose of methotrexate. It's quite common for these women, those who have received methotrexate, to complain of some amount of pain. About 50% of them will complain about pain. So assess these women very carefully. Don't assume that the pain is because of the separation of the trophoblast that is there. Sometimes, even after methotrexate, there could be a tubal rupture possible. So examine the woman very carefully. If the pain is very severe, if you are getting any signs and symptoms of intra-abdominal bleed, then this patient might need surgical follow-up. So coming to something which is very important and which is a very favorite in the exam, you have to remember what are the contraindications for methotrexate. So absolute contraindications are hemodynamic instability or a ruptured ectopic. You will never give methotrexate. Anyone with chronic liver disease, active pulmonary disease, or pre-existing blood dyscrasias, anemia, leukopenia, thrombocytopenia, immunodeficiency, including HIV, anyone with peptic ulcer disease or renal impairment. These are all strong contraindications for methotrexate. Even a woman who is breastfeeding, because methotrexate is excreted in milk. And last but not the least, remember hypersensitivity to methotrexate. All these are contraindications. Whereas hypertension, diabetes, high BMI, controlled asthma, prior ectopic pregnancy, prior IVF pregnancy, or age, these are not contraindications. Okay? So please remember the contraindications and what are not the contraindications for methotrexate. It would come as an SBA for you. Now coming to surgical management. So remember that salpingectomy is the default procedure unless the contralateral tube is damaged. Approach is preferably laparoscopy whenever that is possible. Laparotomy if the patient is very unstable or you do not have the facilities for laparoscopy. And the default procedure is a salpingectomy, whereby it means that the affected tube is removed. When would you do a salpingotomy? Whenever there are any risk factors for infertility, or especially where the contralateral tube is damaged or this contralateral tube is absent, then in those cases, don't remove the remaining tube that is there. Just go ahead and do a salpingotomy. Now, after a salpingotomy, HCG has to be done every weekly until it becomes negative. We already saw that there is a chance of 4 to 11% of women having persistent trophoblast after salpingotomy. And about 1 in 5 women need further treatment after salpingotomy. Because this is a surgical procedure, any woman who undergoes a salpingotomy for a tubal ectopic pregnancy, she has to receive anti-D 250 international units regardless of the gestational age. Any woman who undergoes a surgical procedure, she will undergo UPT after 3 weeks after the procedure has been done. And remember, future fertility is usually not affected. So whether it is salpingectomy versus salpingotomy, similar IVF and natural conception is possible if the contralateral tube is healthy. If the woman already has risk factors for infertility, then you cannot say that the future fertility is not affected. But in women where the contralateral tube is not damaged and the salpingectomy has been done, the future natural conception rates are not affected. Okay. Now coming to non-tubal ectopic sites. Okay. So, and what are the management options for all these? So if you have a cervical pregnancy, first line management is usually medical management or methotrexate, and surgery is offered only for life-threatening bleeding because these cervical ectopics, they are very difficult to manage even by surgical options. So preferably you will give them medical management. Now, if it is a cesarean scar pregnancy, if the patient is stable and the criteria have been met for methotrexate, so please remember the criteria for methotrexate, if they have been met, you can give systemic methotrexate. If the woman doesn't want systemic methotrexate, then locally you could inject methotrexate into the gestational sac or even local potassium chloride so that the fetal heart stops. Okay. And this procedure is usually done either laparoscopically or through the hysteroscope. Or for a cesarean scar pregnancy, if she doesn't want any medical management, surgical suction resection is most effective. Now, this is also again done usually through the hysteroscope, or it could be hysteroscopy plus laparoscopy combined. Now, for an interstitial pregnancy, it could be an expectant management if the patient is stable, beta HCG levels are falling. It could be expectant management. If the criteria are met, you could also offer medical management, or if surgery is needed, then a corneal resection has to be done. And usually laparoscopic is preferred for that. Whenever there is pregnancy in a rudimentary horn, it is almost surgically that is done, and excision of the rudimentary horn is done. For ovarian pregnancy, you can offer medical management. Usually surgical options are the one preferred, where you are doing wedge resection of the ovary, or sometimes even an oophorectomy is required. Abdominal pregnancies, usually the early ones, less than 12 weeks, surgical management is offered and in the form of laparoscopy. If it is an advanced abdominal pregnancy, laparotomy is needed. And it is very important that you localize first where is the placental site, and because you are expected to have torrential hemorrhage, because this placenta, it erodes into all the possible surfaces that are available. Now, whenever you have a heterotopic pregnancy, that means there is an intrauterine pregnancy as well as an ectopic pregnancy. Now, if the woman desires that she wants to continue the intrauterine pregnancy, then obviously you cannot give methotrexate. So, for the ectopic pregnancy, you can inject local KCl or hyperosmolar glucose, or surgical removal of the ectopic pregnancy and preserve the intrauterine pregnancy. Now, if the woman doesn't want the intrauterine pregnancy, you can give her methotrexate. So that will take care of both the intrauterine as well as the extrauterine pregnancy. Now coming to cesarean scar pregnancy. Okay. So first of all, it is important that you diagnose the cesarean scar pregnancy. What are the risk factors that are associated, and what causes recurrent cesarean scar pregnancy? Incidence is about 1 in 1800 to 1 in 2500 pregnancies. Why does a pregnancy get implanted into the cesarean section scar? So that depends on the size of the anterior uterine wall defect. If the defect is very large, someone who is having previous surgeries on the uterus, like previous multiple cesarean sections, or someone who has undergone a myomectomy, if there is a scar, there is a defect in the anterior uterine wall, it is very likely that the pregnancy goes and gets implanted there. Or someone who has had a breach, the previous section was done for a breach for reasons unknown, it is likely that these women in the future pregnancy, they could have a cesarean scar pregnancy. Now, recurrence risk factors. So, whenever the uterine segment thickness is less than 5 millimeters, okay, so it is likely that this woman, she could have a recurrence of this cesarean scar pregnancy. Now, sometimes you have this gestational sac that is bulging into the uterovesical fold. Always think like any woman who has had a previous cesarean scar pregnancy with bleeding and pain. Okay, they could have a recurrence. So a previous cesarean scar pregnancy is always a very high risk factor for recurrence. Now, to diagnose a cesarean scar pregnancy, transabdominal and transvaginal scanning is enough. You routinely do not need to do an MRI or CT for diagnosis of cesarean scar pregnancy. On ultrasound, the features are very clear. Uterine cavity is empty. Cervical canal is also empty. It is closed or empty. And very nicely, you can see the gestational sac that fills the scar niche. Okay. And you can also see that the myometrium is almost absent, or it is very thin between the gestational sac and the bladder. Okay. So Either you can see the placenta that is there embedded in the cesarean section scar, or it could either be the gestational sac. So the ultrasound pictures are very clear. You need not do a transvaginal or transabdominal scan for that. Now, sliding sign is something that we see in either a tubal pregnancy or an ovarian pregnancy. But this is not a feature of a cesarean scar pregnancy. So if you see a positive sliding sign, that means when you are doing an ultrasound scan and you see that the sac that is there, it is sliding away from the scar, from the lower uterine segment scar, then you immediately know that this is not a cesarean scar pregnancy, because sliding sign, it rules out a positive sliding sign, it rules out a cesarean scar pregnancy. Because unlike other, like a tubal ectopic pregnancy, it is a pregnancy that is mobile. Ovarian pregnancy, that ovary is going to be mobile in the abdomen. But when you have a cesarean scar pregnancy, this sac that is there, it is firmly adherent to the lower uterine segment. So it doesn't move when you are doing a scan. Okay, so positive sliding sign, if it is there, if you see, it effectively rules out a cesarean scar pregnancy. Now, if the patient is stable and the criteria are met, you can give systemic methotrexate. Definitive management is either surgical, or you can either do a suction or you can do a resection. Resection is said to be more effective than doing a suction. Alternatives to systemic methotrexate or surgical management, you can give KCL or methotrexate into the gestational sac. And if you see a scar pregnancy that is non-viable, that means only the sac is there, or you see the CRL, you see the fetal pole with no cardiac activity, it is possible to give an expectant management to these women. Sorry, just 1 minute. Now coming to abdominal and heterotopic ectopic pregnancies. So abdominal, we saw the incidence is about 1% of all ectopics. What is the definition? A primary ectopic pregnancy, a primary abdominal ectopic pregnancy is where the trophoblast, it attaches solely to the peritoneal surface. Okay, you know there is primary and a secondary abdominal pregnancy. So in primary means the trophoblast is attached only to the peritoneal surface. It is the attachment of the placenta you will not see anywhere inside the uterus. And this pregnancy is less than 12 weeks. Then only you will call it as a primary abdominal pregnancy. Whenever you have this early abdominal pregnancy less than 12 weeks, you can offer surgical management in the form of laparoscopy. If it is an advanced pregnancy, then laparotomy is usually advised, and it is very important to locate where is the placenta, because of the torrential bleeding that is associated with removal of the placenta. Most of the times it is preferred that the placenta is left in situ. Yeah. Now, whenever you have an abdominal pregnancy which is situated either in the liver or spleen, these are very difficult to manage because there is a risk of life-threatening bleeding that is there with surgery. So these are usually managed medically. Okay. And if you can avoid surgery, you could do angiographic arterial embolization, especially for liver or spleen. This is the first line that is preferred because of the risk of torrential hemorrhage that is seen with surgery. Now, whenever there is a heterotopic pregnancy and the woman, she wishes that she wants to continue the intrauterine pregnancy, then local potassium chloride or hyperosmolar glucose can be injected into the ectopic pregnancy, or you could do surgical removal of the ectopic pregnancy, thereby conserving the intrauterine pregnancy. In an heterotopic pregnancy, when the intrauterine pregnancy is not desired, you can give systemic methotrexate. It takes care of both intrauterine as well as the extrauterine pregnancy. And the incidence of heterotopic pregnancy, Whenever it is a spontaneous conception, it is about 1 in 30,000, whereas for IVF, it increases to 1 in 3,000. Okay, so you see this woman, she is 28 years old, gravida 1. She has a confirmed right tubal ectopic pregnancy, hemodynamically stable, no significant pain. The adnexal mass measures 24 millimeters, with no fetal heart. Serum HCG is 1200. Which of the following is not a contraindication to methotrexate? Please read the question very carefully. Not a contraindication. Okay. So chronic liver disease, active pulmonary disease, pre-existing blood dyscrasia, immunodeficiency, or hypertension. Which is not a contraindication? Remember, A, B, C, D. All of these are contraindications, whereas hypertension is not a contraindication for methotrexate. Please remember. So if this woman, she fulfills all the criteria that we require for methotrexate management, she can be given methotrexate. And also you have to tell her that to avoid a pregnancy for 3 months, avoid alcohol and NSAIDs, and she should also stop folic acid if she is taking that. Okay. Now next, coming to recurrent miscarriage. So you have to know about antiphospholipid. What about TSH and women with thyroid antibodies? What is the role of surgery in uterine anomalies? Whether karyotyping is indicated for all patients, and what about cervical length? So there are different definitions. RCOG says that more than or equal to 3 losses. We already saw it could either be consecutive or non-consecutive losses. Eschery says more than or 2 losses, and even the American Society says more than or 2 losses. Now the risk of miscarriage, it depends on the maternal age. So at 12 to 19 years, the risk is about 13%, whereas when you go to the extreme, that is more than 45 years, see, the risk is about 93%. Okay. So the recurrence that is there after previous losses, it goes on increases. If there is no prior miscarriage, the rate of miscarriage in this pregnancy is about 11.3%. If there is 1 prior loss, it increases to 17%. With 2 to 3 losses, it is 28%. And if you have someone with 6 prior losses, the rate of miscarriage for this pregnancy is around 63.9%. Okay. So you might have to memorize these tables because you might get them in the exam. Now coming to risk, recurrent miscarriage, what are the risk factors for these? So demography, the age of the woman. If the age of the woman is less than 20 years or more than 30 years, the risk of miscarriage increases. For the male, if age is more than 40 years, if the BMI, it is either too low or either too high, so less than 19 or more than 25, and some races like black ethnicity, they are more at a risk of recurrent miscarriage. Now, lifestyle. Whenever women, like there are habits of smoking, alcohol, caffeine consumption more than 200 milligrams per day, erratic working hours like shift hours, they are working day shifts and night shifts, and poor or unbalanced diet. All these increase the risks for recurrent miscarriage. What are the medical factors? So women with antiphospholipid syndrome, those who have thyroid antibodies, subclinical hypothyroidism, women with polycystic ovarian syndrome. Now, of course, you should be calling it as polyendocrine metabolic ovarian syndrome, the new name for PCOS. And if there is sperm DNA fragmentation, all these are medical reasons for recurrent miscarriage. Now, in the first trimester, uterine factors like septate and bicornuate uteri, they could increase the risk. In the second trimester, arcuate, septate, and bicornuate uterus, they are seen to be associated with recurrent miscarriages. And the strongest cytogenetic association is seen with trisomies. So this is the commonest cytogenetic cause of miscarriage. So this slide is very important. You have to know what are the risk factors that are associated with recurrent miscarriages. Now there is an exhaustive list of investigations that you would do. RCOG recommends to do antiphospholipid antibodies, that means lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1 antibodies. You will do thyroid function test, TSH plus TPO antibodies, 3D ultrasound of the pelvis to rule out any uterine anomalies. If there are more than 3 miscarriages, like starting from the 3rd miscarriage, cytogenetic analysis of the products of conception. And if cytogenetic abnormalities are found in the products of conception, only then parental peripheral blood karyotype is done. Otherwise, karyotype is not done. Okay. What is not routinely recommended? So, inherited thrombophilia testing, especially factor 5 lead-in. Immune testing, that means natural killer cells or HLA or cytokines, infection screen, torch. Previously, it was very much in fashion to do torch. Nowadays, not recommended at all. Sperm DNA fragmentation testing, reproductive hormone testing, FSH, LH, AMH, and please do not offer empirical aspirin and heparin in any woman without testing for APS. Only if APS is positive, it makes sense to give aspirin and heparin, because without confirmed APS, these two drugs, they do not improve the outcomes for a pregnancy. Now coming to antiphospholipid syndrome, what are the laboratory and the clinical criteria and what are the treatment options? So clinical criteria, any one criteria is enough to diagnose as APS. So more than or equal to 3 consecutive miscarriages, which are at less than 10 weeks of pregnancy, more than 1 or equal to morphological normal fetal loss, more than or equal to 10 weeks of pregnancy, more than or 1 preterm birth at less than or equal to 34 weeks of gestation owing to placental disease. That means it was either preeclampsia or IUGR, or there is an episode of vascular thrombosis. A minute. Now, which is not a clinical criteria for diagnosis of APS? Any woman with preeclampsia, she has delivered later than 37 weeks. Okay. If she has delivered at term, it indicates that there is no placental insufficiency. So it rules out, it is not a clinical criteria to diagnose APS. Now the lab criteria. So lupus anticoagulant should either be positive, any one should be positive, either lupus anticoagulant, anticardiolipin antibodies, or anti-beta-2 glycoprotein 1, even if one is positive. But remember, it has to be done 2 times, 12 weeks apart. Now, if the results are discordant, that means the first time one of the results is positive, the second time it is not positive, or the first time the results are negative and it is positive only on the second time. That means the results are discordant. So you will go ahead and you will do a third test, which is going to be the decider test. The strongest association is seen with lupus anticoagulant more than with anticardiolipin antibody. Now, any woman who has been diagnosed with antiphospholipid syndrome, the treatment option for her is to give aspirin 75 milligrams and low molecular weight heparin, starting once the pregnancy test is positive, and you will continue it until 34 weeks of gestation. Never use empirically aspirin and heparin in non-APS recurrent miscarriage. It is not going to improve the pregnancy outcome. Now, next coming to the role of thyroid. What about translocations and the role of uterine septum? So, any woman who is euthyroid, but she has TPO antibodies. thyroid peroxidase antibodies are positive, but she is euthyroid. So for these women, there is no benefit from giving thyroxine treatment. Any woman who is TPO positive. So during pregnancy, you will check her thyroid function tests between 7 to 9 weeks and in each trimester. If she becomes hypothyroid, only then thyroxine will be given or thyroid replacement therapy will be given. As long as she remains euthyroid, please do not give any thyroxine treatment. Now, anyone with subclinical hypothyroidism and TSH is more than 4, you will consider thyroxine treatment. Okay, even subclinical, remember subclinical. On the other hand, if it is between 2.5 to 4, TSH between 2.5 to 4, that means it is mild subclinical. Subclinical hypothyroidism is also divided into 3, mild, moderate and severe. So 2.5 to 4 is mild, 4 to 8 is moderate, anything more than 8 is severe. So anyone with moderate, whenever TSH is more than 4, you will give thyroid replacement therapy. Anyone with history of subclinical hypothyroidism previously, you will check TFTs at 7 to 9 weeks of pregnancy and in each trimester. Okay, because it is likely that during the course of her pregnancy, she will become hypothyroid because the need for thyroid hormones, it increases as pregnancy advances. Now you have a couple who has a balanced translocation and you find that it is causing recurrent miscarriages. So you will offer them genetic counseling where PGT could be an option for them or donor gametes could also be an option. In these couples, natural conception is still possible. It doesn't mean that because there is a balanced translocation, they have to go in for PGT or for donor gametes. Natural conception is still possible. And remember, the risk of having an unbalanced translocation in the offspring, it is very low. Women with a uterine septum, there is no benefit from a septal resection. Okay, so RCOG says that if you want to do a septal resection, it will be done only in a research or an audit context. It is not routinely offered to anyone. With regards to cervical insufficiency giving rise to recurrent second trimester losses, then you will discuss the pros and cons or the benefits of cervical cerclage, and you will offer either history indicated or ultrasound cerclage to these women. So you have this 38-year-old, gravida 3, para 0. That means she has had 2 abortions till now, 2 previous first trimester miscarriages, and she attends the preconception clinic. She has been diagnosed with primary antiphospholipid syndrome because lupus anticoagulant is positive on 2 occasions 12 weeks apart. What is the most appropriate management plan for her in this pregnancy? Please remember, whenever you have someone with diagnosed antiphospholipid syndrome and coming with a pregnancy, by default, you will start for her aspirin, low molecular weight heparin, once pregnancy test is positive and continue till 34 weeks. No other option should come to your mind. And this will be the correct option. Okay. So aspirin 75 plus low molecular weight heparin, starting once the pregnancy test is positive, continue until 34 weeks of pregnancy. At that point, you can stop low molecular weight heparin and aspirin she can continue until delivery. Remember, only aspirin or only low molecular weight heparin is not going to help in any woman who has antiphospholipid syndrome. And if antiphospholipid syndrome is not diagnosed, please do not use aspirin and low molecular weight heparin empirically. It doesn't improve the pregnancy outcome. Now, next coming to gestational trophoblastic disease. So, complete and partial mole, placental site trophoblastic tumors, what is the FIGO scoring, and something about UK registration. A lot of questions do come from molar pregnancies, and we have been learning about them right from our MBBS years, first MRCOG part 1. So, I think in MRCOG part 2, it should not be very difficult to answer these questions. Coming to the differences, it has to be pit pat at the back of your mind. What are the differences between a complete mole and a partial mole? So the karyotype in a complete mole, it is diploid and everything comes from the father. Okay, so it is either 46XX or 46XY. The mechanism by how you get a complete mole is you have one sperm which fertilizes an empty egg, and then that sperm it duplicates. Or sometimes, very rarely, you have two sperms that are fertilizing an empty egg. So because the egg is empty, always the karyotype is 46. In complete mole, there is no fetal tissue. All the villi that are there, they are swollen or they are hydropic. Beta HCG levels are very high. On ultrasound, you do not see any fetus. The ultrasound picture is very typical. You see either a snowstorm appearance or you will see like a grape, cluster of grapes. Theca lutein cysts, very common with complete mole. As opposed to that, in a partial mole, see it is triploid. Because how does this partial mole happen? You have a normal egg which is fertilized by two sperm. Okay, so from the normal egg you will get 23 chromosomes. From the two sperms you will get again 23 and 23. So that is why it is triploid. And in the partial mole, like the name suggests, you will have a fetus, but you will have some hydropic degeneration of the placenta. And because the karyotype is abnormal, this fetus usually doesn't grow into a normal baby. You will either have a miscarriage or you will have an intrauterine fetal death or something like that. The villi, some of them are normal and some of them are hydropic. Because it is not a complete mole, beta HCG is only little bit elevated. And on ultrasound, you can see a fetus, like either a normal fetus or someone with uterine and with abnormality seen on ultrasound. And in the placenta, you can see cystic changes. Theca lutein cysts are very rarely seen with a partial mole. Now, what about the risk of gestational trophoblastic neoplasia? That means after the mole has been evacuated, what is the risk of GTN? So with a complete mole, it is about 15 to 20%, less with a partial mole, 1 to 5%. Risk of choriocarcinoma is higher with a complete mole, 2 to 3%, less than 0.5% with a partial mole. And theoretically, because a complete mole doesn't have any RBCs, there are no RBCs, like there is no fetus there at all, only the villi that are there. So NTD is not required after evacuation. Okay. After evacuation of a mole, of a complete mole, theoretically NTD is not required. Whereas with a partial mole, if the mother is Rh negative, the partner is Rh positive, you need to give NTD. Okay. So I'm talking this about theoretically, but what happens is that whenever you send any tissue for histopath, the result takes at least about 4 days to come back. And we know that if at all you want to give NTD, it has to be given within the first 72 hours. 48 to 72 hours is the time you want to give to prevent sensitization of the woman. So practically, even though it is a complete mole, because even if there is one RBC or a little bit of RBCs that are there, they are going to sensitize the mother. So theoretically, you do not need to give NTD for a complete mole, but practically it is, yes, it is given after evacuation of any molar pregnancy. Now coming to the diagnosis and management of gestational trophoblastic disease. So remember, okay, let us first see about how these women are going to present. So presenting features are sometimes quite vague. You will not come to a diagnosis unless you see the ultrasound picture or you see her passing out the vesicles. So they can present with vaginal bleeding. They can present with hyperemesis. On clinical examination, you can see that the uterus is large for dates. Then like whatever period of amenorrhea you're expecting, the uterus will be larger than that. She can present with early preeclampsia, hyperthyroidism, especially because beta HCG and TSH, the alpha subunit is similar. So because we saw that in the molar pregnancy, the rate of there are very high levels of beta HCG. So TSH could sometimes be suppressed, and then you get hyperthyroidism. Now the diagnosis is ultrasound pictures, serum beta HCG, and definitive diagnosis of molar pregnancy is only after histology. Whether it is a complete mole or a partial mole, only histology will confirm. Treatment of choice for a molar pregnancy, whether it is a complete mole or a partial mole, it is always surgical evacuation. Now, when you are doing the surgical evacuation also, remember you will avoid using the sharp curette, the sharp end of the curette, because this uterus, which has a molar pregnancy, is a very soft uterus and there is a very high risk of perforation, or there could be embolization of these villi through the arterial or venous channels. So sharp curette is always avoided, and because of the risk of embolization, medical management is avoided. Now coming to histology. So it is recommended that any woman who has undergone a miscarriage and she is undergoing surgical management of the miscarriage, then all the products have to be submitted for a histological examination, because we saw it could be a partial mole. Okay, so from all the products of conception from a miscarriage, they have to be submitted for histopathology. Not the products like any woman who is undergoing a termination of pregnancy, abortion. And on that, on ultrasound, if you see that the pregnancy is normal, then those products need not be sent for histopathological examination. But any woman who has had a miscarriage and she is undergoing a surgical management of the miscarriage, it has to be that the products of conception have been sent for histopathological examination. Now in the UK, it is mandatory that all women with a molar pregnancy or all women with a gestational trophoblastic neoplasia, they should be registered with the Gestational Trophoblastic Disease Centre. 3 centres are there in UK: Charing Cross in London, Sheffield in Weston Park, and Dundee in Ninewells. Now coming after this, once the molar pregnancy has been evacuated, follow-up is very important. So we all know that if it is a complete mole, if the HCG comes down to normal within 8 weeks of evacuation of the mole, then that is the complete follow-up. Okay, then for these women, the follow-up will be for a period of 6 months. So once the pregnancy has been terminated or the molar pregnancy has been evacuated, HCG will be done weekly for 3 weeks. Okay, weekly until negative 3 times. So 3 times weekly HCG is negative. It will be done, and then it will be done monthly for 6 months. This is for those of whom where the beta HCG comes down to normal within 8 weeks of termination of the pregnancy. Okay. If by 8 weeks the beta HCG has not come down to normal, the follow-up is every monthly for 12 months. Okay. I hope this is clear to all of you. Then after a partial mole, we know that 2 beta HCG negative 4 weeks apart, and the follow-up is complete for a partial mole. So till then, you will do beta HCG every weekly until negative. So 3 times it is negative, and then 1 confirmatory test 4 weeks later. That is the end of follow-up for a partial mole. If the pregnancy, it's a molar pregnancy, complete molar pregnancy, anti-D is not required. If it is a partial mole, then definitely anti-D is required. Now this is the FIGO chart for FIGO scoring for any woman who has gestational trophoblastic neoplasia and she requires chemotherapy. So you have to take into consideration the age, the antecedent pregnancy, interval since the previous pregnancy, pre-treatment HCG levels, what is the largest tumor size, the site of metastasis, number of metastasis, and whether there is any prior failed chemotherapy. Taking into consideration all these points, the score of the woman, it could either be 6 or less than 6 or 7 or more than 7. Whenever the score is 6 or less than 6, we say that this woman is at a low risk, and for her single agent chemotherapy in the form of methotrexate. Okay, methotrexate is given for 1 week, alternating with folinic acid. So methotrexate for 1 week, alternating with folinic acid, then rest for 6 days. Okay, so for this women, those who have a low risk for GTN, or the score is less than or equal to 6, the success rate of the treatment is 100%. Whereas for women whose score is more than equal to 7, they require multi-drug chemotherapy. The commonest is imaco, that is etoposide, methotrexate, actinomycin D, cyclophosphamide, and vincristine. And for them, the cure rate is around 94%. So this chart is something that is very important. It has to go on your study watch, and you should be able to calculate what is the score for women, whether you want to give single dose or you want to give multi-drug chemotherapy. Now, do you routinely give chemotherapy to any woman who has undergone evacuation of a molar pregnancy? No. There are some criteria. Okay. So that is why we are following up these women very meticulously, and we are doing the beta HCG levels. Now, if the beta HCG levels, they become plateaued. Okay. So 4 measurements over 3 weeks, that means on day 1, 7, 14 and 21, you see that the levels are not falling and they are remaining the same. That means the levels have plateaued. Or if the levels of beta HCG, of the levels of HCG, they are rising. More than 10% increase over 3 measurements over 2 weeks. So day 1, 7 and 14, if you see that the measurements are rising. Or histologically, you are going to send all the products, or if the woman has undergone, unfortunately, if she has undergone a hysterectomy or whatever, there is choriocarcinoma, or there is sometimes she has undergone some surgical evacuation of the uterus, and you see there is a placental side trophoblastic tumor. All these are again indicators to give chemotherapy. If the woman post-evacuation of the molar pregnancy, she has heavy persistent vaginal bleeding, or she has gastrointestinal bleeding or an intraperitoneal bleeding, all these are again indications to start chemotherapy for her. If the HCG is more than 20,000, 4 weeks after the evacuation. Okay. And at this point of time, you cannot do a re-evacuation of the uterus, because it is this woman, she is at a very high risk of having a uterine perforation. The uterus has become very soft. So whenever beta HCG levels are more than 20,000, you will always give chemotherapy rather than doing a re-evacuation of the uterus. Whenever you have pulmonary, vulval or vaginal metastasis, it is an indication to give chemotherapy unless the HCG levels are falling. Okay. Whenever there are metastases seen in the liver, brain or GI tract, these are very high risk metastases. So irrespective of the HCG levels, whenever you see metastasis in liver, brain and GIT, always the metastases are treated with chemotherapy. How long do you continue chemotherapy? So you will continue chemotherapy until HCG comes down to normal. Once HCG comes down to normal, you will repeat the courses again for 6 consecutive weeks. From the time HCG is normal, for further 6 more weeks, chemotherapy is continued. And you will tell these women that they will avoid a subsequent pregnancy for 12 months after chemotherapy. Okay, for any woman, 12 months after chemotherapy, she should avoid a pregnancy because of the risks of chemotherapy, stillbirth, or fetal growth restriction, or any anomalies that are seen in the fetus. For other women, those who do not require chemotherapy, they should be avoiding a pregnancy until the period of follow-up is finished. That means for women with a complete mole, they should be avoiding a pregnancy for at least 6 months after evacuation. For those who have a partial mole, at least till 2 HCG levels 4 weeks apart, they are normal. Okay. Now, next, coming to placental site trophoblastic tumor. So, this is a very distinct entity from choriocarcinoma. For this, surgery is the treatment of choice and not chemo. Okay. So, it is a rare gestational trophoblastic neoplasia which arises from the intermediate trophoblastic cells. It is there on the placental site only. It is something very rare, less than 2% of all gestational trophoblastic neoplasia. The antecedent pregnancy is often a term pregnancy. It could be a long time ago, months or years previously also. And beta HCG rise is not very high. So that is why it is not a very reliable marker. On the other hand, human placental lactogen, we know it comes directly from the placenta. So that is a better marker for PSTT. And the first line treatment for PSTT is doing a hysterectomy. If at all there are any metastasis or the interval from the pregnancy is more than 2 years, then chemotherapy is added. And usually the chemotherapy that is given, it is a multi-drug regime. Single drug chemotherapy doesn't work. On the other hand, you have placental site nodule, which is a benign finding. It is many a times an incidental finding, and for that no treatment is required, no chemotherapy or no surgery is also required. Now, in the subsequent pregnancy, there is a high risk of, it is possible that you will get recurrence. So, in subsequent pregnancies, surveillance is done lifelong, like after every pregnancy, but they also say that 10 years after the initial GTN that is there, if after a pregnancy the beta HCG is not rising, then after 10 years, these women can be put off surveillance. There is no need to continue the surveillance after 10 years from the index pregnancy where she had a gestational trophoblastic neoplasia. Now coming to contraception, okay. The rule that you have to remember, all types of contraceptives are suitable. They are not contraindicated. But the only thing is intrauterine devices you will not use for these women till HCG comes down to normal. Okay. So it is not that hormones are contraindicated or anything, but because the uterus has become very soft, intrauterine devices you will not put until HCG comes down to normal. Okay. Why? Because there is a risk of perforation if the molar tissue remains. So no IUD. Once the beta HCG or the HCG becomes normal, all types of contraceptives are acceptable. When will you counsel the woman for a pregnancy? So with low risk chemotherapy, that means her score was 6 or less than 6, she can use contraception for a period of 6 months after the end of chemotherapy and then plan a pregnancy. Whereas if she was a woman with a high risk, 12 months after the end of chemotherapy, then she can plan a pregnancy. Okay. Any woman after a molar pregnancy, she has not received any chemotherapy. She has to wait until the HCG is normal for 6 months. Like after 58 days, it becomes normal. The follow-up ends after 6 months. What is the risk of a subsequent molar pregnancy? So it is 1 in 80 after 1 mole or 1 in 5 after 2 moles. Now, what about the histology? Like if she has had a molar pregnancy previously, the second time again she has a miscarriage. Okay. So at that time, if there is a miscarriage, you will send the products of conception to make sure that it is not a molar pregnancy, because we saw that there is a risk of 1 in 80 of her getting a recurrent molar pregnancy. And any woman who has had a molar pregnancy previously, after the end of even a normal pregnancy, you will do HCG at 6 weeks and 10 weeks postpartum. Actually, this was given in the older guidelines. The newer guidelines, they say that there is no need to check HCG at the end of 6 weeks and 10 weeks postpartum. If it was previously only a molar pregnancy, not requiring any chemotherapy or anything. On the other hand, if it is gestational trophoblastic neoplasia, then after each pregnancy, you will do the HCG levels. Now, what about some special situations? What about the monitoring schedules there? So if there are brain metastasis, she needs multi-drug chemotherapy. You can also give intrathecal methotrexate, and you can give cranial irradiation. Or you can, even if there is a space occupying lesion, you can do a neurosurgery if it is a very discrete lesion. For liver metastasis, again, multi-drug chemotherapy, and she might need hepatic artery embolization. If it is lung metastasis alone, the lung metastases are thought to be low risk. So whatever is her FIGO score, depending on that, you will treat her with chemotherapy. After evacuation, how frequently, after evacuation of any molar pregnancy, HCG monitoring, how frequently to do? Weekly until 3 consecutive levels are normal. Then you will do monthly. Okay. So theca lutein cysts, they regress as the HCG levels fall. There is no need for surgical removal of the theca lutein cysts. Please keep this in mind. Now, hyperthyroidism in molar pregnancy, it is seen quite frequently. It is because of the structural similarity between beta HCG and TSH. This hyperthyroidism is transient and it doesn't need any treatment. You will have to treat only the hyperemesis that is associated with this molar pregnancy and with the hyperthyroidism. And any woman who presents very early with preeclampsia, usually eclampsia is supposed to start after 20 weeks of pregnancy. Any woman presenting earlier than that, always suspect a molar pregnancy. So you have this 32-year-old woman who had a complete molar pregnancy, evacuated 8 weeks ago. Day 1, beta HCG level is 15,000. Day 14, it is 14,800. Day 28, it is 14,500. Day 42, it is 15,200. What is the most appropriate next step for her? So just think what is happening to the beta HCG levels. They have almost plateaued. They are 50. On day 1, it is 15,000. And day 42, again, it is 15,200. Definitely, this is not something that is normal. She will need some form of treatment. What will you do for her? Will you just do weekly surveillance? Not acceptable, because you see that the beta HCG levels are not falling. Will you do repeat evacuation? Could be a possibility. What is the other? Single agent methotrexate chemotherapy. They have not given anything else for her, like whether she has METs or whatever. Multi-agent chemotherapy or hysterectomy. These two definitely not indicated. Not a hysterectomy, because she's just day 42 and they have not given anything else suggesting that it is a it is choriocarcinoma or anything. So the best option here is single agent methotrexate chemotherapy. Why? Because you see that the beta HCG, it has plateaued over 4 weeks. And whenever you get plateauing of beta HCG, that is an indication for a chemotherapy. Now, if you try to calculate her scores, okay, her age is less than 40. So that is 0. Then it is a complete mole. So it is again a score of 0. The time interval between evacuation is less than 4 months. Then the beta HCG score is between 10⁴ to 10⁵. That is a score of 2. And there are no METs. They have not given anything about METs. So it is just a score of 2. A score of 2 means it is less than or equal to 6. So that is why single agent methotrexate alternating with folinic acid to prevent the toxicity of methotrexate. Okay, that is given, and the cure rate for this is about, it is 100%. Okay. Now next coming to hyperemesis. So here you have to know about the puke score, what is the antiemetic ladder, and what is the role of thiamine. So the new guideline, it indicates that GDF15 is the hormone. Previously, we thought it is HCG that is implicated for hyperemesis gravidarum. The new guideline says that it is this growth hormone type 15, which is growth factor like 15, which is implicated in hyperemesis gravidarum. So the definition of nausea and vomiting of pregnancy is there is nausea and vomit, nausea plus or minus vomiting, which starts at less than 16 weeks of gestation, and there is no other cause for this nausea and vomiting. It affects about 90% of pregnant women. Whereas, on the other hand, hyperemesis gravidarum, it is a severe form of nausea and vomiting and affects about 0.3 to 3.6% of pregnant women. So the recent guideline, it says that there is hypersensitivity to this growth differentiation factor 15. This GDF15 is the reason for the nausea, for the vomiting, for the sense of like alternate sense of smell or the nausea, whatever is there, rather than the high levels of HCG. So these women, those who have been taking treatment for nausea and vomiting of pregnancy or for hyperemesis gravidarum, in these women, this GDF15 is found to be markedly raised. Self-reported, what about recurrence? We know that anyone with this previous history of hyperemesis, she has very high risk of recurrence. It is about 89%. And about 10% of women, they undergo termination of a wanted pregnancy because of hyperemesis gravidarum. So it's about 10% of women, they want the pregnancy, but they are not able to tolerate the nausea and they're not able to tolerate the hyperemesis gravidarum. So they prefer to undergo termination of pregnancy. Which are the common comorbidities that are associated with hyperemesis gravidarum? So multiple pregnancy, we know molar pregnancy, previous hyperemesis gravidarum, and extremes of BMI. That means someone with a very low BMI, BMI of less than 19, or someone with morbidly obese. They are the ones who are prone to hyperemesis gravidarum. Very important thing that has been pointed out in this guideline is about ketonuria. Please remember, ketonuria, it is not an indication of the severity of hyperemesis, or it is not an indicator of dehydration. So ketonuria should not be done to monitor what is the response of treatment. Okay, this like urine ketones 4+, we always thought that it indicates severe dehydration. But remember, ketonuria is something which is physiological in pregnancy, and ketonuria is not an indication of dehydration. Now, any woman who is pregnant and presents to you with hyperemesis gravidarum, please do not think by default that this is hyperemesis gravidarum. A host of other conditions could mimic this. So gastroenteritis, urinary tract infections, cholecystitis, appendicitis, diabetic ketoacidosis, thyroid storm, raised intracranial pressure, all of these could present with severe nausea and vomiting in pregnancy, and they have to be ruled out before labeling the woman as having hyperemesis gravidarum. Now, anyone who presents to you with hyperemesis gravidarum, you have to do a host of tests to make sure what is the underlying pathology. So, if you do have biochemical tests, you will find that in hyperemesis, there is hyponatremia, there is hypokalemia, serum urea is low, hematocrit is high because of the dehydration, and there is metabolic hypochloremic alkalosis. Remember, in hyperemesis gravidarum, It is metabolic alkalosis. It is not acidosis. Unless the hyperemesis gravidarum is very severe, then you have metabolic acidosis. Otherwise, initially, it is always metabolic alkalosis. Thyroid function is abnormal in about 66.67% of the cases, and there you get a transient gestational thyrotoxicosis. But please do not treat this hyperthyroidism or this thyrotoxicosis with drugs. It is not necessary. Once you have treated the hyperemesis gravidarum or at the end of the first trimester, thyroid function tests come back to normal. LFTs are abnormal in about 40% of the cases, where you get a rise in transaminases. Bilirubin also might be raised, and pancreatic amylases might be mildly elevated. Now, very important question as to why the TSH is suppressed in women with hyperemesis or in HG. So remember, HCG and TSH, they are structurally same. Alpha, and they have alpha and beta units. So the alpha unit is same for both. Beta unit is different. Now in women, we know any pregnant woman, HCG is going to be raised, and there is more of this alpha subunit of the HCG, which is very similar to the alpha of TSH. So because this alpha of HCG is raised, the brain thinks that there is too much again of this TSH roaming around, so TSH production decreases. TSH production decreases, that is why you get a biochemical thyrotoxicosis. It is not really thyrotoxicosis. T3, T4 levels are normal, and there is no need to treat this thyrotoxicosis. Then midstream urine sample you will do to rule out urinary tract infections. You will do an ultrasound to confirm the gestation. Look out for multiple pregnancy, look out for a molar pregnancy, because these two conditions are very frequently associated with hyperemesis gravidarum. Now you have very severe hyperemesis gravidarum, or you have cases that are refractory to all your treatment. In those cases, in addition to all the above investigations, you will also do blood gases. You will do serum amylase because you want to rule out pancreatitis. You want to look out for disorders in glucose metabolism. So you will do a blood glucose level, and also you will do liver ultrasound because you could be having some liver abnormalities. One thing that you have to remember about in hyperemesis is that please do not treat this biochemical thyrotoxicosis. It settles down by itself. Okay, once the hyperemesis is controlled, or at the end of first trimester, it settles down by itself. If at all you have in a question that you have this woman with hyperemesis and she has thyrotoxicosis, do not choose carbimazole or PTU as your answer. Remember, the treatment is, the correct option is always supportive care, IV fluids and antiemetics. So treat the hyperemesis. Do not treat this first trimester thyrotoxicosis. Now coming to the PUC score and HELP score. So PUC score, though it is called as a PUC 24 score, remember the maximum score that you can get is 15. You will never get a score of 24. Now based on what is this PUC score, you have hyperemesis divided into mild, moderate and severe. So less than or equal to 6 is mild, 7 to 12 is moderate, 13 to 15 is severe. So there are 24 components that are there in this PUC score. It is about the nausea, for how many hours duration it is there, the number of vomiting episodes and the number of etching episodes. Now this PUC score that is there, it is there only to quantify the severity of the nausea and vomiting, whether she needs admission or she doesn't need admission, and what is the treatment response. But sometimes it has been found that this PUC score, though it is very helpful to know whether this woman needs admission, she needs inpatient admission or she doesn't need inpatient admission, this PUC score is not really very helpful to know this treatment response. Okay. So wherever you want to know how the woman is responding to your treatment for hyperemesis gravidarum, you have this HELP score. It is basically used to assess the severity and the treatment response, where puke is thought to be less useful. Puke is very useful to decide whether the woman needs inpatient admission or you can treat her on an outpatient basis. Sorry. Now, not all women, those who present with hyperemesis, they need inpatient admission. Okay. There are some indications for that. Any woman who has continued nausea and vomiting and she is not responding to oral antiemetics, or any woman who has dehydration and she has lost more than 5% of her booking weight. She is on oral antiemetics, but still she is losing weight. She is looking dehydrated. Any woman who has any suspected comorbidity like UTI, diabetic ketoacidosis, or cholecystitis, or any women who have comorbidities like epilepsy, diabetes, HIV, Addison's, or any psychiatric disease. Any one of these indications, you will not treat on outpatient basis, you will treat on inpatient basis. Now, it's very important you know the step-up line for treatment. So there are first-line drugs, second-line drugs, and third-line. In first line, you have cyclizine, promethazine, chlorpromazine, or prochlorperazine. It's important that you know the dosages at least of 1 or 2 drugs. Okay. If the woman doesn't respond to your first-line drugs, then second-line drugs in the form of metoclopramide or domperidone or ondansetron can be given. Older guidelines said that metoclopramide do not give for more than 5 days. The new guideline says if the woman is responding to metoclopramide, there is no harm in continuing it for a period of more than 5 days also. But one thing you have to be very careful with metoclopramide, always rule out any liver disease. In those patients, you will not give metoclopramide. And also if there is allergy, like if she develops extrapyramidal symptoms with metoclopramide, then you will not give. Okay. Third line, when first line and second line drugs fail, then third line is hydrocortisone. So initially you will give it in an IV form, 100 milligrams 2 times a day. Once the woman settles down, then you can switch to oral prednisolone, 40 to 50 milligrams once daily till she improves, and then slowly you will taper it off. Please do not taper off abruptly. Slowly you will taper off the drug. Wherever there is refractory hyperemesis, that means all your first line, second line, third line drugs have failed. This is the time when you need a multidisciplinary input. The gastroenterology team has to be there with you, and you will consider enteral tube feeding, or you will put her on total parenteral nutrition. Now, to treat hyperemesis gravidarum, specific fluids are advised. You will always use normal saline, 0.9%, guided by daily electrolytes. If you see that there is hypokalemia, then potassium chloride is added in each bag. If there is no hypokalemia, no need to add potassium chloride. If at all you want to give dextrose, please remember you have to first give thiamine supplementation. Do not give dextrose without giving thiamine supplementation. Otherwise, you will precipitate Wernicke's encephalopathy in these women. So before giving 5% or 10% dextrose, you will either give oral 100 milligram TDS thiamine, or you will give injection Pabrinex. Only after thiamine supplementation has been done, then you will give dextrose. Any woman who is admitted for more than 3 days with hyperemesis gravidarum, low molecular weight is indicated. Very important to remember is from this slide is that please do not give dextrose containing fluids without prior thiamine supplementation. Otherwise, you will precipitate Wernicke's encephalopathy, which is a potentially life-threatening condition. Sometimes maternal deaths have occurred only because of giving dextrose as the intravenous fluid therapy. So please do not give it without giving injection thiamine. Now, what about the drugs? Are they very safe? So ondansetron in the first trimester, there is a very small risk of cleft palate, extra 3 cases per 10,000. So whenever you are giving the drug, always have a good discussion with the patient and then prescribe the drug. Metoclopramide, extrapyramidal side effects, especially when you are giving the drug intravenously. Cyclizine is the first line treatment. There are no significant teratogenic drugs risks with this drug. Steroids you will use only after first line and second line drugs have failed. Routinely, steroids are not used. Doxylamine and paradoxin, they are not used in UK. They are first line in US, but not in UK. So for this exam, don't choose the option of doxylamine and paradoxin. Paradoxin alone also, there is insufficient evidence in hyperemesis gravidarum. In mild nausea and vomiting, B6 might help. Ginger, not of any use in hyperemesis, but for mild nausea and vomiting, there is some evidence of benefit. Acupressure might be useful for some women with mild nausea and vomiting. Now remember, there is a special group of women, those who have DKA, like type 1 diabetics with hyperemesis gravidarum. What happens is, because of the vomiting, their insulin requirements drop. They stop injecting themselves with insulin. Whenever there are no stores of insulin left, they are at a very high risk for diabetic ketoacidosis. So any woman who has hyperemesis gravidarum, like any woman with type 1 diabetes and hyperemesis gravidarum, always be on the lookout whether she is developing DKA or not. And for these women, it is best that you admit them for IV fluids, and insulin you will give them according to a sliding scale. That is the best way to prevent DKA in these women. Now you have this 28-year-old woman, 10 weeks of gestation with hyperemesis gravidarum. She has hyponatremia, hematocrit is raised, TSH is suppressed, free T4 is mildly raised. No goiter, no tremor, no past thyroid history. Most likely explanation for her thyroid biochemistry. If you have listened to the whatever I spoke previously, you will know that structural similarity between HCG and TSH, that is the reason why there is her thyroid biochemistry is altered. Okay, because of the structural similarity between beta HCG and TSH. And this biochemical thyrotoxicosis, please remember, it doesn't need any form of treatment. You only have to treat the hyperemesis gravidarum. Now, next coming to pregnancy of unknown location. So, HCG ratios, M5, M6 models, linear regression models, again biostatistics, which I don't like at all. And then you have the 48-hour decision tree. But don't worry, we will not be talking about biostatistics. NICE doesn't advocate doing any logistic regression module. NICE has simplified it very much using the 48-hour algorithm for beta HCG. Okay. Now, what is a pregnancy of unknown location? Whenever you cannot see any pregnancy on ultrasound, but urine pregnancy test is positive. No intrauterine, no extrauterine pregnancy, but pregnancy test is positive. That means this lady, she has a pregnancy of unknown location. Okay. Now, what are the outcomes for these women? So, 30 to 50 of them, the pregnancies fail. 30 to 50% of them, later on, you will see an intrauterine pregnancy, and 10 to 20% of them turn out to be an ectopic. So how do you manage these women, those who have pregnancy of unknown location? You have diagnosed, UPT is positive, you have done a TVS, you cannot see intrauterine pregnancy, you cannot see an extrauterine pregnancy also. First step that you have to do is you have to do HCG levels and repeat the HCG after 48 hours. Remember, after 48 hours, you will not do an HCG before that. If you do before that, it is not diagnostic. Okay. So there is this M5, M6 model, which is a logistic regression model using initial HCG and 48-hour HCG ratio to predict the outcome, whether it is failing, intrauterine or an ectopic pregnancy. In routine practice, we use whatever NICE tells us. Okay. So you will do HCG 48 hours apart, and then based on whether the HCG is rising or it is falling or whatever, then you can make out whether it is intrauterine, extrauterine, or it is a failing pregnancy. One thing you have to remember is that if your beta HCG is 1500 ml, 1500 international units per liter, you have to be able to see an intrauterine pregnancy on a TVS. Okay, beta HCG more than 1500, no intrauterine pregnancy seen on TVS. Please don't label her as pregnancy of unknown location. If nothing is seen intrauterine, definitely it is extrauterine. It is an ectopic pregnancy then. Okay. There is something called as a persistent PUI. So whenever the HCG plateaus without intrauterine or an extrauterine pregnancy being identified, consider it as an occult ectopic pregnancy and either offer her methotrexate or do a surgical exploration. Now coming to this 48-hour HCG decision tree. So you have done the serum HCG at 0 hours. You have repeated it again at 48 hours. Three things will happen. Either there will be a rise. Now, if the rise is more than 63%, that means at 0, it is low, 48 hours. It has increased to more than 63%. Previously, we called it as doubling, but actually the rise should be more than 63%. It is likely that it is an intrauterine pregnancy. And for these women, remember it is likely. So 7 to 14 days later on, you will offer her a TVS to find out whether you can see the intrauterine pregnancy or not. At the other end, you will have a fall in HCG. Now, if the fall in HCG is more than 50%, that means at 0 hours, the HCG is high. At 48 hours, when you do, it has fallen. Then it is likely to be a failing pregnancy of unknown location. So for these women, you will do UPT again at 14 days. If at 14 days UPT is negative, she is out from the follow-up. If it is positive at the end of 14 days, you will send her to the early pregnancy assessment services. The third scenario, there is a rise, but it is not more than 63%. Okay, that means the rise is not optimal. Or there is a fall in the beta HCG, but the fall is not more than 50%. The fall is less than 50%. These two are very suspicious for an ectopic pregnancy. So anyone where the rise is less than 63% or the fall is less than 50%, you will refer them to early pregnancy assessment services within 24 hours. They are likely to be ectopic pregnancies. Now, how do you calculate what is the percentage rise? So, HCG at 48 hours or day 3 HCG minus day 1 HCG divided by day 1 HCG into 100, that will give you the percentage of change, whether it is 63% or 50% or whatever is the change. Based on that, then these three scenarios and you will manage. But at any point of time, you see that the patient is hemodynamically unstable or she has severe unrelieved pain. Then don't wait. Don't say, okay, let me do my HCG again after 48 hours. Then I'll tell you whether you have an ectopic pregnancy or you have a falling pregnancy. Anytime the patient becomes unstable, do not wait for HCG levels. Go ahead and surgically do an emergency surgical exploration for her, or you might lose the patient then. Okay. So let us see a few examples of this PUL. So day 1 HCG is 500, day 3 it is 900. That means if you remember the equation that I told you how to do it, it is an 80% rise. So it is likely to be intrauterine pregnancy. Advise TVS in 7 to 14 days for her. Day 1 HCG is 1500. Day 3 it is 2400. That means the rise is 60%. It is a suboptimal rise. So it is suspicious of ectopic. So refer to early pregnancy assessment services within 24 hours. Now day 1 HCG is 2000. Day 3 is 1900. That means it is falling. But remember the fall is only 5%. So either it is a plateauing or it is an inadequate fall. Again, it is suspicious for ectopic. Refer immediately to early pregnancy assessment services. Day 1 HCG is 1200. Day 3, it is 400. The fall is 67%. So it is a likely failing pregnancy. You will repeat UPT in 14 days. Day 1 HCG 800, day 3 400. So the fall is 50%. Remember, the fall should be more than 50%. Here the fall is exactly 50%. That means it is a borderline. So it could potentially be an ectopic. So refer her to the early pregnancy assessment services. Now, persistent pregnancy of unknown location. That means the HCG is plateauing after 3 measurements. Always consider it to be an occult ectopic and refer her for laparoscopy or for methotrexate. If on day 1 HCG is 8,000 and you're doing a TVS and you cannot see intrauterine pregnancy, I already said once HCG is 1500, you should be able to see an intrauterine pregnancy. With 8,000 HCG and no intrauterine pregnancy, it will definitely be an ectopic. So you will always refer her or you will always offer her surgery. Then UPT is positive 14 days after a failing PUL diagnosis. This again is also very suspicious either of a molar pregnancy or ectopic. So you will refer her back to early pregnancy assessment services within 24 hours. Okay, unless she has severe pain or bleeding, then the referral will be immediate. Now coming to some special scenarios where you have either heterotopic pregnancies or you have pregnancies due to in vitro fertilization or there are bilateral lesions. Whenever you have an IVF pregnancy plus pregnancy of unknown location, remember IVF, there is a very high background risk of ectopic pregnancy, almost about 3%. So earlier scan threshold, that means at TVS, whenever it is more than 1000, always do a TVS and you should be able to see where is the pregnancy. PUL with previous ectopic. Always there should be a higher index of suspicion for an ectopic pregnancy. So earlier intervention is indicated for these women. Now you have a pregnancy of unknown location and there is an adnexal mass. Now this mass is separate from the ovary. Always treat it as an ectopic. Okay. Admit and manage as per NICE algorithm. Pregnancy of unknown location in the patient on an enzyme inducer. Standard pathway, but you have to see what drug she is on and whether that drug is having some interaction with methotrexate. Then you will not consider giving methotrexate. You will offer her only surgical management if it is an ectopic pregnancy. If it is a heterotopic pregnancy, if the intrauterine pregnancy is desired, locally you can inject potassium chloride into the ectopic pregnancy, or you can offer surgery and preserve the intrauterine pregnancy. Now you have this failing pulmonary, failing PUA, that means pregnancy of unknown location. When is she discharged from follow-up? Once the UPT is negative at 14 days post initial assessment, then there is no need for further follow-up and you can discharge the patient from follow-up. Now coming to abortion care. Okay, so remember the clauses of abortion A, B, C, D, E, F and G. These are very important because you will have a lot of questions based on this. So this slide is very important. It has to be on your study wall. Now in UK, remember abortion is legal and this is the Abortion Act and there are various categories under which an abortion can be offered to the mother. So clause A, pregnancy puts mother's life, that means continuance of this pregnancy, it will put the life of the mother at risk rather than terminating the pregnancy. So this is clause A, and for this there is no upper limit when the termination of pregnancy can be done. Normally up to 24 weeks only pregnancy can be terminated, but if the mother's life, if continuation of the pregnancy is putting the mother's life at risk, even if the pregnancy is more than 24 weeks, at any time the pregnancy can be terminated. Now, continuation of the pregnancy, it will cause grave permanent injury to the mother's mental or physical health. That is clause B. Even for this clause, there is no upper limit to gestation. Even after 24 weeks of pregnancy, it can be terminated based on clause B. Clause C, it says that continuance of pregnancy, it risks injury greater than termination, mental or physical, including social or family. But here the pregnancy has to be less than 24 weeks only. Okay. Clause D is continuance of the pregnancy. There is injury to existing children of the family. Even here, the pregnancy has to be less than 24 weeks only. And clause E, there is substantial risk that the child would suffer from serious physical or mental abnormality. Even here, there is no upper limit where the pregnancy can be terminated. After 24 weeks also, the pregnancy can be terminated. Now, clause F and G, this is for emergency terminations. So, whenever you want to save the life of the pregnant woman, so similar to clause A, but now this is done in an emergency. Here also there is no upper limit. And clause G is when you want to prevent grave permanent injury to the mother. Here also no time limit is there. At any period of time, even after 24 weeks, the pregnancy can be terminated. Another thing you have to remember whenever you are offering termination of pregnancy, if the woman comes to you after 21 plus 6 weeks of pregnancy and you want to terminate the pregnancy, then feticide should be explained, or it should be done to prevent the risk that the child that you will get a live born fetus. Okay. So anytime before 24 weeks, a pregnancy can be aborted. But if the pregnancy is more than 21 plus 6 weeks, before you initiate the procedure of termination of pregnancy, feticide has to be done. And then after that, the process of termination will begin. Let us see examples of the clause. Okay. So pre-existing diabetic nephropathy or plus pregnancy, clause B. That means you want to prevent grave injury, already prevent permanent injury. So this woman already she has diabetic nephropathy and now she's pregnant again. If the pregnancy continues, we know that anyone with severe renal disease and the pregnancy continues, her pre-existing renal condition might worsen. So under clause B, you can offer her termination of pregnancy, but it can be done at any point of time, even after 24 weeks of pregnancy. Any woman presenting with bleeding, hypotensive shock, cervical osseous open, it is an emergency procedure to save the life of the woman. So clause F. Now, this woman, she is a multipara. This is her 5th pregnancy and she doesn't want to continue it because it is going to affect the care of the rest of her children. So clause D. But here the pregnancy has to be less than 24 weeks of pregnancy, not after 24 weeks. It has to be less than 24 weeks of pregnancy. Any woman with Marfan syndrome, aortic loop dilatation, more than 50 mm, under clause A, because if the pregnancy continues, it puts her life at risk. So even after 24 weeks of pregnancy, you can terminate the pregnancy for someone with Marfan's and a dilated aortic root. Fetus with anencephaly, clause E, because it is incompatible with life and there is severe mental or physical risk to the baby. Pregnancy due to failed contraception, C, because it is social reason or whatever. But again, here also, it has to be less than 24 weeks of pregnancy, not after 24 weeks. If the pregnancy is because of rape or incest, again, clause C is applicable, but pregnancy has to be less than 24 weeks. Any woman wanting to have medical termination of pregnancy because the baby has talipes, no clause is applicable for that. Selective feticide, that means sex selection, even for that, there is no clause that is applicable. Now, you have any woman, any pregnant woman who's coming with heavy PV bleeding at night following rape. She is crying and you have done a pregnancy test and it is positive. This pregnancy can be terminated on clause C or clause G. Sorry, it is emergency. to prevent grave permanent injury to the mother. Okay. So these are examples, various examples of what are the clauses under which pregnancy can be terminated in UK, or you can offer termination of pregnancy in UK. Now, before doing abortion or doing termination of pregnancy, always STI screen is done. And if it is a surgical termination, then antibiotic prophylaxis has to be given. So STI testing is routinely offered. Chlamydia and gonorrhea NAT test is done. If it is a surgical abortion, doxycycline, 100 milligrams 2 times a day is given for 3 days. It is started on the day of procedure. For medical abortion, no antibiotic prophylaxis is given. If the woman has allergy to penicillin or to doxycycline, then azithromycin is given as an alternative, 1 gram as a stat dose. VTA assessment for all women, it is being done. And if at all needed, then low molecular weight heparin is given for more than or equal to 7 days. If the woman is at a very high risk of venous thromboembolism, the low molecular weight heparin is started before the abortion and you will continue it for a longer period of time. Now, whenever pregnancy is terminated, remember there is a risk that the pregnancy might continue after a surgical abortion. That the risk is about 1 in 1,000 of either an incomplete abortion or you can have an ongoing pregnancy. After an abortion, medical termination of pregnancy, according to the new guideline, there is no need for anti-D. And regards to histology, it is not mandatory to send all the products for histology. You will do a naked eye examination of the products of conception and confirm that it is a pregnancy tissue. If at all you are suspicious, only then you will submit the tissue for to rule out a molar pregnancy. Otherwise, for any woman undergoing a medical termination of pregnancy, it is not mandatory to submit the tissue for histological examination. So this is the new guideline for abortion care, which says that for both medical and surgical abortion at less than 12 weeks, there is no need to give anti-D immunoglobulin. Less than 12 weeks. If it is more than 12 weeks, standard of care applies for anti-D administration at gestational age more than or equal to 12 weeks. Okay. So this is the new abortion care guideline. Now coming to the priming of the cervix. So you can either prime the cervix with mifeprostone, misoprostol or osmotic dilators. When the pregnancy is less than or equal to 13 plus 6 weeks, you can give misoprostol 400 micrograms 1 hour before, or if you want to give sublingual, if you want to give vaginal, you will give 3 hours before. Or mifeprostone, you can give 200 milligrams 24 to 48 hours before the procedure is done. If the pregnancy is between 14 to 16 weeks, you can give either osmotic dilators or misoprostol or mifeprostone. It is or osmotic dilator or mifeprostone or misoprostol. Please do not give all of them together. Okay, only one has to be given. 16 to 19 weeks, you can give osmotic dilators or misoprostol. 19 to 23 plus 6 weeks, osmotic dilators are usually recommended. You can add mifeprostone 200 milligrams or osmotic dilators 1 day before. But never two will not be given together, like osmotic dilators and mifeprostone. You will not give together. It is either osmotic dilators or mifeprostone. Okay. Now for pain management, you can give NSAIDs, local anesthesia, conscious sedation, plus or minus a paracervical block. This is basically for surgical procedures. General anesthesia is not routinely recommended because there are risks of complications and also stay in the hospital is longer if you give general anesthesia. Now, if at all the woman wants general anesthesia, for any reason general anesthesia is needed, then IV propofol is used and you can add a short-acting opioid like fentanyl. Inhalational anesthesia is usually avoided. Because if you use inhalational anesthesia, then hospital stay increases. And NHS, we know it is very conservative. They want to make the hospital stay as short as possible. Now coming to medical abortion and what is post-abortion contraception. Long-acting reversible contraceptions you can initiate on the same day that a medical abortion has been done or even surgical abortion has been done. Okay. So medical abortion less than or equal to 9 plus 6 weeks. Or we already saw the same thing that is there for a miscarriage. So mifeprostone 200 milligrams and 24 to 48 hours later you can give misoprostol 800. 9 to 6 weeks there is an option of home expulsion. She can expel the products of conception at home itself. If it is more than 10 weeks, then usually she is recommended to expel the products in the clinic because there could be more bleeding that is there. Now in this regimen, mifeprostone is given to her in the clinic and the misoprostol tablets are given to her and she is advised to take the tablets at home. Okay. When the pregnancy is between 12 to 23 plus 6 weeks, mifeprostone 200 milligram is given and then 24 to 48 hours later, misoprostol doses 400 micrograms every 3 hourly. Of course, this is in the hospital. It is not home expulsion. Please remember that. Coming to contraception. So, whenever you have done a surgical abortion or for medical abortion, you have given mifeprostone, on the same day, an implant can be inserted. Okay. If the woman wants an intrauterine device like a copper coil or she wants a Mirena intrauterine system, at the time of surgical abortion, once the procedure has been completed, you can immediately insert the copper coil or Mirena, or if she is undergoing a medical termination, once the expulsion is complete, immediately after that, you can insert an IUCD or Mirena. With DMPA, the first dose of DMPA, it can be given. So remember, these women, they are coming for mifeprostone, they are coming to the clinic. So the same time that you are giving them mifeprostone, at that time itself, you can give the first dose of DMPA. There is a theoretical small risk of an ongoing pregnancy, but overall this risk is low. So in the UK, they are still doing that. The first dose of mifeprostone, when it is given, at the same time, DMPA can also be given to the woman. The other types of contraceptives, that means combined hormonal contraceptives or POP or a patch or a ring, you can start it on the same day as mifeprostone or on any day after. And as regards to the follow-up of these women, those who are undergoing a medical abortion, UPT at 3 weeks after the procedure has been done, whether it is surgical abortion or she is undergoing a medical management. If the UPT is negative at 3 weeks, it confirms that the abortion is complete. So you have this 17-year-old at 18 weeks of gestation. She has an anencephaly on an anomaly scan and she requests termination. So under which clause of the Abortion Act does this fall? So this falls under clause E. Okay. That there is substantial risk that the child would suffer serious physical or mental abnormalities, because anencephaly, it's a lethal fetal anomaly and it is not compatible with life. And for this, if it is more than 21 plus 6 weeks, feticide has to be done. Okay, and 2 doctors have to be signing this HSA1 form. If it is an emergency, then it is enough that 1 doctor will sign the form. If it is clause F or clause G, then it is enough if 1 doctor signs. And again, here remember, for this clause E, the upper limit of 24 weeks, that doesn't apply. at any time of pregnancy, once it is diagnosed, even if it is diagnosed, she is coming to you late in pregnancy, she comes to you at 26 weeks and you find that there is anencephaly, even though it is more than 24 weeks, because it is clause E, you can still terminate the pregnancy even at 26 weeks. But you will do first feticide and then terminate the pregnancy. Now, next, coming to uterine perforation. So, in uterine perforation, it is important to remember the sites, the commonest sites where the uterus can be perforated, and what are the types of instruments that can cause uterine perforation. So, the most common procedure that leads to uterine perforation is termination of pregnancy. That is the commonest. Hysteroscopy is comparatively rare, about 1.6% is only caused due to hysteroscopy. While inserting an IUD, 15% of IUD perforations, they involve the abdominal or the pelvic viscera, and bowel injury is there in about 3 to 7.5% whenever the uterus is perforated during intrauterine device insertion. The most common site of perforation is the anterior uterine wall, then cervix, then right lateral, left lateral, posterior wall, and fundus is the least common site for perforation. The most high-risk instrument that causes perforation when you are doing a surgical termination of pregnancy is the suction cannula. 51% of the perforations are due to a suction cannula, then curette, and then the Hagar's dilator. Now, uterine perforations are not seen for each and every woman who is undergoing a termination of pregnancy. Some risk factors. So, abnormal position, acutely anteverted or a retroverted uterus. If the cervix is stenosed, okay, like prior cervical surgeries are there. Then if it is a scarred cervix, like prior conization or LEDS procedure has been done. If it is post-CS, where the cervix has not dilated, post-myomectomy, where the myometrium has become very thin, or any scarred uterus is at a high risk of perforation. Now, whenever you're doing a procedure, how will you know that you have perforated the uterus? Most common is sudden loss of resistance, or whatever instrument that you are using, that instrument you notice that it is just going inside into the uterine cavity. Then the instrument falls in, like sudden loss of resistance, and the instrument suddenly falls down. You can get sudden bleeding. If you are doing the procedure under local anesthesia, the patient will complain of severe excruciating pain. So if at any point of time, severe excruciating pain, stop the procedure immediately. You know that you have perforated the uterus, or suddenly you notice that your instruments are going inside very easily. That also indicates that there could be a site of perforation. Now, if you have a perforation, don't leave the woman as it is, because very high chances of a lot of complications happening. But remember that the management rules are different for a curette, if the perforation is happening by a curette, or whether it is happening by a suction cannula. So if the perforation is happening because of a sound, or it is a dilator, remember these instruments are small instruments, and they are blunt instruments. So the damage that they are going to cause is not very, it's not, they will not cause bowel injury or unlikely to cause vascular injuries. So for them, management can be conservative. You can just observe them. If there is any risk of infection, you can give antibiotics, and to relieve pain, you can give analgesia. On the other hand, whenever a perforation occurs during a termination of pregnancy with a suction curettage, with the suction cannula, or with a sharp curette, these instruments, they are likely to cause more damage to the intra-abdominal organs. So laparoscopy is mandatory to rule out a bowel or a vessel injury. And under laparoscopic guidance, then you can continue the termination of pregnancy. If you don't see any other injury anywhere else, under laparoscopic guidance, you complete the procedure of termination of pregnancy. Whenever you have a confirmed visceral injury, you will do a laparotomy and a repair. Always remember to involve the general surgeon in scenarios like this. Whenever the patient becomes hemodynamically unstable, don't wait and do only observation. Always do a laparotomy immediately because you are suspecting a vascular injury at that point of time. If the perforation occurs during a hysteroscopy, okay, but you are using a sharp, or like you are doing a septal resection, or you are doing a polypectomy, or some surgical procedure you're doing with hysteroscopy, then you will always do a laparoscopy to exclude any visceral injury. If it is only a diagnostic hysteroscopy, then you can offer her only conservative management and antibiotics. If the uterine cavity is opened up, like distension and the uterine cavity has been opened up, you can give antibiotics. Otherwise, if it is only diagnostic hysteroscopy, you can just offer conservative management. If you have caused a uterine perforation like by putting in an intrauterine contraceptive device, always do an X-ray immediately, a pelvic X-ray, AP view and a lateral view, and also you will do an ultrasound to confirm where is the intrauterine contraceptive device. If it has been misplaced into the abdominal cavity, you can go ahead, do a laparoscopy and retrieve the IUD. And at any time, if you think that the bowel has been injured, always you will give broad spectrum antibiotics to prevent sepsis. The two important things to remember here, that whenever it is a suction cannula, perforation occurring due to a suction cannula, always you will do a laparoscopy to rule out injury to the bowel or to vessels. Whereas if the perforation is due to a dilator or it is due to a sound, then the patient can be observed if she is stable and there are no concerning signs. Now, next coming to maternal sepsis. So again, this is a new guideline. So you can expect more questions here. You should know what is the definition, the WHO definition of maternal sepsis, what is sepsis 3 definition, and then what is septic shock. So WHO says maternal sepsis is life-threatening organ dysfunction due to infection during pregnancy, childbirth, post-abortion or postpartum. Any life-threatening organ dysfunction due to infection, that is maternal sepsis. Now, what is the sepsis 3 definition? So you have any infection and the sequential organ failure assessment that is more than or equal to 2. Then it is called as sepsis according to the sepsis 3 guideline. And what is septic shock? Whenever you have any person or any woman with sepsis and there is persistent hyperperfusion despite fluids, despite giving adequate fluid replacement, the mean arterial pressure remains less than 65 millimeters of mercury or lactate levels are more than 2 millimoles per liter. So hypotension or hypoperfusion in spite of adequate fluid replacement, that is your septic shock. Why we are so worried about this is because it accounts for 11% of maternal deaths globally. In UK, maternal mortality from sepsis is about 2.5 per 100,000 maternities. That means 100,000 births. The risk of invasive gas infection, it is 20 times for a pregnant woman as compared with non-pregnant. So gas is something you have to be very careful of in the pregnant ladies. And postpartum, the risk of invasive gas, it is up to 80% than non-pregnant. And the risk is very high, especially in the first 28 days. Embrace UK states that sepsis remains a leading direct cause of maternal death. So that is why we are very scared of sepsis and it has to be treated immediately. Now, not all women are at a risk for sepsis. So there are some risk factors: obesity, diabetes, iron deficiency anemia, age more than 35, any woman who is immunosuppressed, Black minorities, then any woman, any pregnant lady in the postpartum period, if she has contact with any woman, with any person with invasive gas infection, any woman who is an IV drug user. Okay. So any of these risk factors, this woman, she is at a high risk of developing sepsis. Some obstetric risk factors. So anyone with rupture of membranes, prolonged rupture of membranes for more than 18 to 24 hours. Anyone undergoing a cesarean section because there is a wound on the skin and the uterus. Both of these are susceptible to infection. Any vaginal trauma, that means vaginal tears or obstetric anal sphincter injuries. Anyone coming with retained products of conception, she can have endometritis. Any invasive procedures done during pregnancy, amniocentesis or a cervical cerclage. Multiple pregnancy, increased background risk of infection. Any woman undergoing a cervical cerclage, there is a risk of ascending infection. Okay. Single pregnancy, remember, is not a risk factor. Multiple pregnancy is a risk factor, but a singleton pregnancy is not an increased risk factor for developing maternal sepsis. One thing that you have to remember about GBS infection, okay? Whenever there is GBS bacteriuria in pregnancy, treat the bacteriuria at that point, 20 weeks, 24 weeks, at whatever time the woman comes to you with GBS bacteriuria, treat the bacteria in pregnancy. And remember that this woman needs intrapartum antibiotic prophylaxis. So the drug commonly used is benzyl penicillin in a dose of 3 grams initially, that is the IV loading dose, and then 1.5 grams 4 hourly. Now this intrapartum antibiotic prophylaxis, you will give it once the woman goes in active labor and till she delivers. After she delivers, for the mother, there is no need to continue this intrapartum antibiotic prophylaxis. This GBS prophylaxis, we are basically giving for the baby. So once the mother delivers, unless there are indications, you will not give her any antibiotics. Now coming to the organisms, the latest guideline says that E. coli is the most commonest organism that causes maternal sepsis. You have others also like GBS, anaerobes and all these, but these are the ones. E. coli is the most commonest, and gas or group A, Streptococcus, is the one that causes the most severe infection in the mother, and GBS is for the baby. Okay. So this group A Streptococcus, or gas as we commonly call it, it could be a commensal in about 0.03 to 0.06% of women. But in the postpartum period, because of this colonization that is there, there is an increase in the risk of infection, about 80 times more. 80 times increased risk of postpartum infection. Women, those who have this colonization with gas, they present with watery, non-offensive vaginal discharge. How do these women with gas present, gas infection? It is an ascending infection, so it can cause endometritis. It causes myonecrosis. It can even go into the peritoneal cavity, causing peritonitis. It can cause necrotizing fasciitis, and it can also cause toxic shock syndrome. So this is the whole range of infections that you can get with gas. The best drug for gas is clindamycin because it suppresses the toxin that this Streptococcus pyogenes, whatever toxin is being produced by this streptococci, this clindamycin, it suppresses this toxin. So clindamycin is the best drug that you can give. And if needed, you can add piperacillin and tazobactam, or you can add meropenem. Now, one important thing about necrotizing fasciitis, if the pain is out of proportion to her clinical signs and symptoms, severe excruciating pain, and compared to that, she doesn't have so much of fever or there is not much of tachycardia, but severe pain, always think of necrotizing fasciitis. Okay, so that is all about gas infection. Now, other bacteria that could be causing this postpartum sepsis or maternal sepsis is you have MRSA, or you have PVL producing Staphylococcus aureus. They could lead to mastitis, they could lead to abscesses anywhere, they could lead to pneumonia. Again, for this MRSA or for this PVL Streptococcus aureus, vancomycin is the drug of choice. You have organisms that are ESBL. That means they have extended spectrum beta lactamase. For them, carbapenems are most effective. But whenever you have ESBL, it is always better to involve the microbiologists at the earliest to offer the best type of antibiotics that are suitable for her. Now, whenever it comes to sepsis, remember there are some red flags and there are amber flags. And whenever you suspect sepsis, you have to immediately initiate the sepsis 6 bundle within 1 hour. Otherwise, the rate of mortality is very high. So, if you have any one red flag sign that is seen, if GCS is less than 15, if respiratory rate is more than or equal to 25, if the partial pressure oxygen saturation is less than 95% on air, a heart rate more than 130, systolic blood pressure less than 90, urine output less than 0.5 ml per kg per hour, or there is no urine output for the past 12 hours, or lactate more than or equal to 2. Any one of this is a trigger factor, and immediately you will escalate to the higher authority. That means to the senior obstetrician, your MDT will be involved immediately. Whereas if you have any of the amber flags, any one amber flag is there, you will get a review in 1 hour. But it does not mean that in 1 hour, the nurse is not doing anything. She will do something to make sure that this amber flag, it goes from amber to white. If it still doesn't go, then in 1 hour, she will escalate to the obstetrician. So if the respiratory rate is between 21 to 24, heart rate is between 100 to 129, or systolic blood pressure is 91 to 100, temperature, extremes, like there is hypothermia or there is hyperthermia. If the mental status is changing, okay, if it is acute alteration, that this person was responsive or GCS was alert and suddenly the patient becomes comatose, okay, acute alteration of the mental status, or suddenly the patient becomes very violent. If there is no urine output for the past 12 hours, any patient who has undergone any recent invasive procedure in the last 6 weeks, if there is prolonged rupture of membranes more than between 18 to 24 hours, or if there is a wound infection, this will give you a clue as to what is the source of the infection. Whenever anyone has close contact with someone who has invasive gas infection, and fetal tachycardia, more than 160 beats per minute. All these are amber signs, and you will observe, the nurse will observe for 1 hour. She will try to do something, like if there is systolic blood pressure 91 to 100, she will try to give more IV fluids, or if there is fever, she will try to give paracetamol. And if within 1 hour this amber doesn't become white, then she will escalate immediately. But two things that you have to remember: if lactate is more than 2 at any point of time, more than or equal to 2 at any point of time, urgent review and fluids have to be started immediately. If lactate is more than or equal to 4, it indicates severe hyperperfusion. Severe hypoperfusion. Lactate more than or equal to 4. And immediately there is a need for multidisciplinary team discussion and shifting to intensive care unit. Now let us see about the sepsis 6 bundle. This you have to know by heart, and you will apply the sepsis 6 bundle in any case where there is sepsis. Whenever there is suspected maternal sepsis and there is more than or one red flag sign, 6 things have to be done. Immediately a senior review and escalate within 1 hour if there is no improvement. Second is oxygen. So targeted, like the SpO2 has to be maintained between 94 to 98%. You will start oxygen. You will get IV access and get bloods for investigation. So blood culture, 2 sets, lactate, full blood count, U's and E's, CRP, coagulation profile, and glucose. These are all the things that you will get before starting IV fluids or before starting broad spectrum antibiotics. Broad spectrum antibiotics you will start immediately. Don't wait for cultures. Take blood for culture and immediately start antibiotics. IV fluids also, you have to start immediately. 500 ml of a crystalloid you will give as a bolus. Okay. But if there is hypotension, you can add around 30 ml per kg per hour. If there is hypotension or lactate is more than 4. And you will monitor the patient with a Meo's chart. So urine output basically has to be monitored, and plus blood pressure, her pulse, temperature, respiratory rate, what is her mental status. All of these things have to be monitored, and also lactate will be repeated after 1 hour. So these are the 6 things that have to be done with the sepsis 6 bundle. This you have to know PIT-PAT. Now, once you have given the fluid challenge, if hypotension still persists with the fluid challenge or lactate is more than 4 millimoles per liter, that is the time vasopressors are indicated. So noradrenaline is the first line vasopressor that is indicated. And your target mean arterial pressure should be more than or equal to 65. If this is not achievable, you will transfer immediately to the intensive care unit. Which are the first line antibiotics that you will give? Remember, always it will be broad spectrum antibiotics till the results of culture are available. So Piptaz is the one first line, or you can give meropenem plus clindamycin, because clindamycin, it suppresses the toxins that are released by gas. And if there is risk of MRSA, you can add vancomycin. Now the new guideline says that if the patient is not improving with all your broad spectrum antibiotics, think that there is a viral source of infection. So you can add acyclovir. Empirically, you can even add acyclovir if in spite of broad spectrum antibiotics, the patient is not showing any improvement. Think of HSV infection, herpes simplex infection could also be, it could masquerade as severe maternal sepsis. Now coming to the antibiotics, okay, you not only have to cover the bug, but even the toxins that are being produced by the bug, they have to be suppressed. So Piptaz is a broad spectrum antibiotic. It is effective because it is broad spectrum. It is effective against gram-positive, gram-negative, anaerobes, pseudomonas. The only thing is that it is not effective against MRSA. Very good point is it is renal sparing, but it is not effective in, or you will not use it to anyone who has beta-lactam allergy. Again, meropenem, something which is very broad spectrum. It is effective against extended spectrum bacterium lactabase, ESBL organisms, not effective against MRSA. Okay. Any patient who is not improving with Piptaz, or you are suspecting resistance to Piptaz, then you will use meropenem. Clindamycin is very effective for gas. It is effective against some strains of MRSA. It is also effective against anaerobes. It suppresses the the toxins that are produced by gas. Clindamycin is not excreted renally. Remember, so it can be used in renal impairment. The only risk with clindamycin is the risk of Clostridium difficile. So be careful with this. You can cause Clostridium difficile infection. Co-amoxiclav, it is useful against streptococci. It is useful against MSSA. That means it is also effective against anaerobes, effective against some gram-negative, not effective against MRSA. That means methicillin resistant, it is not effective, but against methicillin susceptible Streptococcus aureus, it is effective, co-amoxiclav. But it is not effective against MRSA, nor effective against Pseudomonas. Do not give co-amoxiclav in late pregnancy because it can cause neonatal necrotizing enterocolitis. And even if it is a preterm delivery and the patient is breastfeeding, even in those patients, co-amoxiclav is usually avoided. Metronidazole given only for anaerobes. It is an adjunct to your other antibiotics. Where antibiotics are not effective against anaerobic infection, you will add metronidazole. Cephalosporins are effective against gas, against GBS, but they are not effective against MRSA or ESBL. And anyone who has severe penicillin allergy, we know cephalosporins are structurally similar to penicillin. So anyone with severe penicillin allergy, do not give cephalosporins. If it is mild allergy, you can still give cephalosporins. Gentamicin only effective against gram-negative. So your coliforms and pseudomonas. Only for those you can use gentamicin. Again, important point to remember, it is nephrotoxic, it is ototoxic, so do not use in pregnancy because it can cause damage to the 8th nerve in the fetus. Whenever you are giving gentamicin, you have to monitor the levels, and you will not give gentamicin alone because it doesn't have any anaerobic cover and it is not effective against streptococci also. Vancomycin is the drug of choice for MRSA. But remember, if you give it very rapidly, you can cause red man syndrome. And also there is renal toxicity with vancomycin. What about immunoglobulins? So any person who has severe gram-positive sepsis, or there is toxic shock syndrome, or there is necrotizing fasciitis that is not responding to your antibiotics, you can give intravenous immunoglobulins. They are given only in the ICU, when the patient is in ICU, and anyone who has IgA deficiency, you will not give immunoglobulins because basically they are not effective in anyone who has IgA deficiency. So choose your antibiotics very wisely. Do not give antibiotics just haphazardly. Okay. Now you have to identify the source of infection, and then you will have to plan your management accordingly. So if the source is a genital tract infection, you will have watery, non-offensive vaginal loss. It could be because of gas infection. Whereas if it is anaerobic infection, you will have offensive vaginal discharge. And for this, whenever you have like vaginal discharge that is there, always look out for retained products of conception in the uterus. You will do an ultrasound and you will do an evacuation under antibiotic cover. Now, if the wound, so it could be either a cesarean section wound, it could be an episiotomy wound, or it could be a cannula also. This causing infection, so there will be erythema and bruising over the wound. And if there is signs and symptoms of necrotizing fasciitis, only antibiotics are not going to help. You will have to do urgent debridement. Whenever there is UTI or pyelonephritis, so dysuria, loin pain, always do a urine culture in sensitivity. And if it is not responding, like repeated urine infections, always do a CT or an ultrasound to look for obstruction. When there is infection in the chest, you are suspecting pneumonitis. So the patient will present with cough, hypoxia, pleuritic pain. So you will do an X-ray chest. And remember, if the BMI of the patient is very high, more than 30, you will do PCR for influenza virus. Because these women, those who are BMI of more than 30, they have a very high risk of developing influenza pneumonia. Now, if there is mastitis or a breast abscess, the breast will be tender. And if there is abscess, then you need to drain the abscess. And flucloxacillin is the antibiotic that works best because usually it is staphylococcal infection. If there is meningitis or encephalitis, the patient will present with headache, photophobia, GCS will be low. That means mentation will be altered. If possible, if it is safe, you will do a lumbar puncture to see, to do a culture and to know what is the organism that is involved. And empirically, you can add acyclovir because if it is viral, then you will not get anything on a culture. If the source of infection is the heart, endocarditis, there will be a murmur. So any patients who are IV drug users or those who are on any metallic valves, for them, they could be at a high risk of having endocarditis. For endocarditis, remember that normally we do blood cultures 2 times, 2 sets are taken. But for endocarditis, 3 sets of cultures are taken and usually they are taken 30 minutes apart. Okay. And echo is another very good source or very good tool to identify the lesions that are there on the valves. So for anyone in whom you are suspecting endocarditis, always get an echo done by your cardiologist. If there is disseminated HSV infection, there could be hepatitis, but in this hepatitis, only the enzymes are raised and bilirubin is normal. Okay. And in this disseminated HSV infection, you can have hepatitis plus or minus encephalitis. Whenever there is no obvious source of any infection, you are giving broad spectrum antibiotics, but the patient is not responding to anything, get a blood HSV PCR done immediately. But don't wait for that. You can empirically start IV acyclovir. Any patient with pain out of proportion to the clinical signs and symptoms, whenever or you have skin blisters and the progression of the disease is very rapid, always think of necrotizing fasciitis and get an urgent debridement done. Give clindamycin and also you can give immunoglobulins. Next, coming to an SBA. So you have this 32-year-old woman who is day 3 post-emergency cesarean section. She complains of severe perineal pain out of proportion to the clinical findings. She has a watery, non-offensive vaginal discharge. She is febrile, tachycardia, hypotension, and lactate is raised, 4.2. So Streptococcus pyogenes, that means group A, is suspected. What is the most appropriate empirical antibiotic combination that you will give for her? For group A, always remember clindamycin you will give because it suppresses the toxin production. And the other antibiotic is something that you want to give, which is broad spectrum. Okay. So Piptaz is the first line. Piptaz and clindamycin because it is gas. So to prevent the toxin that is produced by gas, always you will add clindamycin. Okay. Okay. Now next, coming to perinatal mental health. This is a topic which everybody hates. Just 1 or 2 points you have to keep in mind over here. Anyone with postpartum hallucinations, delusions, always remember it is postpartum psychosis. And you will immediately escalate to the perinatal mental health team, admit the mother in the mother-baby unit, and keep a close watch on the baby. These are 2 or 3 main important points. Then it is very easy to differentiate what is postnatal blues, what is postnatal depression, and then the drugs and everything. Those are something which is very simple, not difficult. But only remember, postnatal delusions and hallucinations, or someone who has history of bipolar disorder, someone who has had previous history of psychosis, postpartum psychosis, very high risk of recurrence, 1 in 2 risk of recurrence. Anybody with a family history of postpartum psychosis, very likely that this woman now has postpartum psychosis. So these few buzzwords, if you see in the question, you will know that this is postpartum psychosis, and then it is very easy to pick up the management options or what is the diagnosis. So you have to screen for the high risk groups. Okay. So woolly 2 questions at booking or in the postnatal period. Remember DDH. If she is feeling down, depressed or hopeless, this is enough for screening. Or you can ask her if you have had little interest in or pleasure in doing any of these things. Now, if she answers positively to any of these questions, then you will offer further assessment by GAD-2 or GAD-7. This is for generalized anxiety scores. Okay. And then you have this Edinburgh postnatal depression scale. It is not a diagnostic, but it is a useful screen to see whether the woman has depression or not. And GAD-2 and GAD-7 is basically to screen for anxiety disorders, generalized anxiety disorders. GAD-2, there are 2 questions. GAD-7, there are 7 questions. Now, high-risk groups. Which are these high-risk groups? Any woman with past severe mental illness, anyone with a bipolar disorder, previous postpartum psychosis, substance misuse, domestic or domestic violence, or a family history of postpartum psychosis. These are high risk groups. So for these, you always have to do screening and make sure that you prevent these disorders developing in them. Now, whenever you are assessing these women, you will also make sure that you rule out any suicidal tendencies, risk to self, risk to the baby. That means she is neglecting the baby or she is having thoughts of infanticide. And also these women, they could be risky to others. And you have to make sure that this woman has the ability to care for the baby or the baby will be neglected. All these things you have to assess in these high risk women. And if you find any of these factors, like she has suicidal ideas, or you think that she is becoming psychotic, she says she's seeing something, she is hearing someone saying something, she has severe depression, or she is becoming maniac, okay, then urgent referral has to be done to the perinatal mental health team. Don't leave out any woman suicidal ideas or hallucinations, delusions, she's becoming maniac. Don't leave these women alone. Immediate referral has to be done to the perinatal mental health team. Why? Because suicide, it is one of the leading cause of maternal death in UK. Now, what is the management? Okay. So if you get baby blues, commonly seen between day 3 to day 10 postpartum, there is no hallucinations, there is no delusion or anything. It is a self-limiting disorder. All that the woman needs, she needs reassurance and she needs support. She doesn't need any antidepressants. It is self-limiting. Then postnatal depression. When it is mild to moderate, if it is first line, you will just give psychological therapy. That means cognitive behavioral therapy. It could be guided self-help or it could be interpersonal therapy. Even for postnatal depression, you will avoid antidepressants routinely. Initially, you will not give antidepressants. If it is moderate to severe, then you can give a combination of antidepressant plus cognitive behavioral therapy. Antidepressants that are safe in pregnancy or in postnatal period, you can give sertraline. It is the first line preferred. It is safe in pregnancy and in breastfeeding also. Alternative SSRI that you can give is fluoxetine. It has a longer half-life and it is hard to taper off. It is not very easy to wean the woman off fluoxetine. A better alternative is citalopram. Paroxetine is one SSRI that you will avoid in pregnancy and also in breastfeeding because it can lead to cardiac defects. Toxepin is also another one that you will avoid. Now, whenever you are giving SSRIs in pregnancy, remember there is something called as neonatal adaptation syndrome. So the baby can show symptoms of withdrawal once the baby is born. And there is a small risk of PPH. PPH means persistent pulmonary hypotension in the fetus. Okay, it is in the fetus. After SSRIs, there is a risk of developing persistent pulmonary hypotension in the fetus. So you will try to avoid it as far as possible. You will try to avoid it in pregnancy. Medication you will give only if the medication outweighs the risks of untreated depression in pregnancy. Otherwise, as far as possible, try to avoid medication. And never stop the medication abruptly. Always the medication will be tapered off. Okay. Whenever there is anxiety, generalized anxiety in pregnancy, the first line therapy is always cognitive behavioral therapy. If it is severe anxiety, you can give SSRIs. Benzodiazepines are avoided for a long period of time. If you need it only for a short period of time, you can give benzodiazepines, but they are avoided over longer period of times. If only to tide over a crisis, you can give benzodiazepine. Now coming to bipolar disorder. So remember, lithium is a drug which you can continue in pregnancy if no other drug is going to work. But valproate definitely contraindicated. At no cost, you will give valproate in pregnancy. Now, one golden rule that you have to remember, if there is a bipolar disorder in pregnancy, you will not start antidepressant alone. You will always give a mood modifier drug. Why? Because if you give antidepressant alone, there is a risk of mania or there is a risk of a mixed state. That means the bipolar could get exaggerated. So never give antidepressant alone. Which are the drugs that you can give for bipolar in pregnancy? Valproate, we saw, it is absolutely contraindicated. Never give valproate to any woman in childbearing age. Carbamazepine also, it can give rise to anomalies in the fetus, so avoid as far as possible. Lithium is one antipsychotic which, if there is no other alternative, you can continue with lithium. But always remember that with lithium, there is a risk of Epstein anomaly. And whenever you are giving lithium in pregnancy, the serum levels have to be monitored. And always the woman has to be well hydrated. You have to be on the watch out for her renal function and her thyroid function. Whenever the woman is in labor, you will stop lithium, okay? And you will restart again in the postpartum period. Every trimester, you will do her lithium levels. Antipsychotics that you can give in pregnancy, the atypical ones, that is quetiapine or olanzapine, these are often used. But remember, even with antipsychotics, glucose tolerance is affected. They are at a very high risk of developing GDM. So you have to be on the lookout. You have to screen for GDM. Any woman with bipolar disorder, once she comes to you in the preconceptional period, you will always review her medicine. You will stop, not stop abruptly valproate, of course, with the help of a specialist. You will cross titrate valproate and you will start off some drug that is safe in pregnancy. You will always involve the perinatal psychiatric team. In the postpartum period, for postpartum prophylaxis of anyone with the bipolar disorder or who has previous postpartum psychosis, you can restart lithium or you can restart the antipsychotic immediately after delivery. Why? Because the recurrence risk is very high. There is more than 25% risk of relapse. There is more than 50% risk of a relapse if there is a personal history or a family history of postpartum psychosis. So it is very important that in the postpartum period, you start the drug immediately and the woman, she is always under observation. You will not leave the woman alone. Now, what about emergency treatment, okay, for puerperal psychosis? Remember, these women, they need admission to the mother and baby unit. You have to start antipsychotics for them. You will plus or minus start lithium. And if needed, electroconvulsive therapy might also be offered to them. So what is the definition of this puerperal psychosis? So basically, it is a severe psychiatric emergency. The onset is shortly after childbirth. And most often, it is a part of the bipolar spectrum disorder. Anyone with bipolar disorder, usually they are the ones who have this puerperal psychosis. Incidence is about 1 to 2 per 1,000 births. Onset is usually within 2 weeks. The highest is 1 to 3 days postpartum. That is the day you're likely to have postpartum psychosis. Features, like I said, delusions, hallucinations, mood swings. That means alternating mania, depression, or mixed behavior, confusion, perplexity, rapid fluctuation in her mood. Anyone having all these features or any of these features, it is puerperal psychosis. Strongest risk factor for developing puerperal psychosis: bipolar disorder, previous puerperal psychosis, or a family history of a bipolar disorder or puerperal psychosis. Recurrence risk, more than 50% if previous postpartum psychosis, 25% if the woman has a bipolar disorder. And if they have no history, then it is only about 0.1 to 0.2%. More than 50% of those who do not have any previous psychiatric history, The first presentation, if it is there in the puerperal period, it is very sudden and catastrophic because it is something that is very unexpected. These women, they do not have any previous psychiatric history and suddenly they present in the postpartum period. So for these women, urgent management is needed, same day psychiatric assessment, and admit to mother and baby unit if possible. If not possible, at least the mother needs admission. Treatment is antipsychotics. Atypical ones are preferred, like we saw, quetiapine, that is preferred, plus or minus lithium, if you want a mood stabilizer, and ECT. If they are not responding to your antipsychotics, not responding to lithium, then sometimes electroconvulsive therapy is also given to these women. The baby is at very much of risk because infanticide, thoughts of infanticide could be there for the mother. Plus the mother, she can neglect the baby. So you have to make sure that child services are involved and the baby is under safeguard. Now, what is the differential diagnosis of this perinatal mental health? Okay. So day 3 to 10 postpartum, she is presenting with tearfulness, there is mild low mood, but it settles down spontaneously. That means it is only baby blues. It is something which is self-limiting. 2 weeks postnatal, there is low mood, poor sleep, she's crying, baby is readmitted for weight loss. That means obviously she is neglecting the baby. Now, poor sleep, low mood, all this is indicative of postnatal depression. If she presents between day 3, 1 to 3, we saw that is the highest period where they present with psychosis. So delusions of the baby being taken away from her, or there is a history of schizophrenia, okay, previously, then this could be puerperal psychosis. She presents day 4 postnatal. She has cut her wrists at 3 o'clock in the night after she had an argument with her boyfriend. But now she is joking and she is very affectionate with her boyfriend. This is something called as a borderline personality disorder. She is sometimes very affectionate, sometimes she is fighting. Then 2 weeks postnatal, she is tearful, anhedonia, there is self-harm thoughts and not eating. So anhedonia basically means that she is no longer interested in doing things which she previously enjoyed. Like previously she enjoyed listening to music, she previously enjoyed reading a good book, but now she is not interested in doing any of the things that she previously enjoyed doing. This again is severe postnatal depression and she requires urgent perinatal mental health assessment. Now, the woman presents 7 days postnatal after a CS. She has low mood, no suicidal tendencies, but she gives history that the mother had bipolar disorder and suicidal tendencies. Very high risk for puerperal psychosis, family history. Okay? So, refer again to the perinatal mental health services. She is 1 to 3 days postpartum. There is severe insomnia, agitation, and delusions are there. Again, whenever you see the word delusions or hallucinations, it is puerperal psychosis. She presents with fever, confusion, and tachycardia, and she is postnatal. Now, always don't assume that whenever someone is presenting in the postpartum period with some psychiatric symptoms, don't assume that it is always a psychosis or depression or whatever. Always rule out any organic cause. So whenever there is fever, any psychiatric illness will not cause fever. Okay, there could be confusion, but even tachycardia is not something that could be caused by a psychiatric disorder. So always rule out any organic cause, rule out any sepsis before you say that this is some mental health issue. Okay. By the way, these are all questions that have appeared in previous papers. Okay, and then you have to basically diagnose what is the psychiatric disorder that is there. Now coming to the drugs or psychotropics, so which are preferred in pregnancy and breastfeeding. Sertraline, we saw it is first line, minimal risk. You can give in pregnancy and whereas in breastfeeding. Fluoxetine also, it is acceptable in pregnancy and in breastfeeding. Paroxetine you will avoid because cardiac defects are there, something like an Epstein's anomaly. You will not give in pregnancy. In breastfeeding, you can give if the mother is stable on paroxetine. Then citalopram or escitalopram, they are both acceptable in pregnancy and breastfeeding. Benzodiazepines you will avoid routinely, basically because neonatal sedation, neonatal withdrawal is there. So even in pregnancy and in breastfeeding, you will avoid benzodiazepines. Valproate contraindicated in pregnancy and in breastfeeding. Carbamazepine also avoid in pregnancy. During breastfeeding, it could be acceptable if no other drug is helping the mother. Then lithium, you can continue if needed, but always talk about Epstein's anomaly and always monitor serum levels in pregnancy. Okay. In breastfeeding, usually lithium is avoided because very high levels are excreted in the milk. So you have to monitor the baby very carefully. Any woman who is on lithium and she's breastfeeding, baby has to be monitored very carefully. Atypical antipsychotics like quetiapine or olanzapine, you can give in pregnancy after case discussion with the specialist team. But remember, any psychotics, very high risk for GDM. So monitor the glucose levels. And in breastfeeding also, they are acceptable. Clozapine, you will avoid in pregnancy. And even in breastfeeding, you will avoid because it can give rise to agranulocytosis in the infant. So this is the safety margin of all these drugs or the psychotropics that you can use in pregnancy and breastfeeding. You have this 28-year-old Gravida 2 Para 1 who is having a bipolar disorder. Now she's planning a pregnancy. She is stable on lithium and valproate for the past 3 years. What is the most appropriate pre-pregnancy advice? First thing that would come to my mind is I will stop valproate for her. So you look out for an option like that. Continue both medications unchanged? No. You want to stop valproate, right? Stop both medications immediately. You cannot do that. You cannot abruptly stop any medication. Cross titrate of valproate and continue lithium with monitoring. Okay, this could be a good option. Switch to fluoxetine alone. That means you have to stop lithium and valproate, which is again not acceptable. Or switch to a tricyclic antidepressant. Not really indicated. We saw that in women with bipolar, you will not start only an antidepressant. So the correct option here is cross titrate of valproate and you continue with lithium monitoring. Okay, that is the correct option. And we saw why all the other options are incorrect. Now coming to postpartum hemorrhage. I'm sorry, we are taking a little bit of a longer time, but it's a longer topic. So please bear with me. We are almost about to finish. Okay. Now coming to postpartum hemorrhage, you have to know the classification: primary, secondary, minor, moderate, severe, and massive. Within 24 hours, any postpartum hemorrhage that is there, it is called as primary. If it occurs between 24 to 12 weeks, 24 hours to 12 weeks postpartum, it is secondary PPH. If the blood loss is 500 to 1000 ml without any shock, it is minor. Moderate is a blood loss of 1000 to 2000 ml. Severe is more than 2000 ml. And massive is loss of more than 2500 ml, or you have transfused more than or equal to 5 red blood units. That is your massive postpartum hemorrhage. Remember the 4 T's, that is tone, trauma, tissue, and thrombin. Out of this, tone is the commonest because we know atonic PPH is the most common cause of PPH. Now, risk factors. Which are the risk factors? Multiple pregnancy, previous postpartum hemorrhage, preeclampsia, macrosomia, failure to progress, that means delayed second stage of labor, prolonged third stage, retained placenta, placenta accreta, episiotomy, or a perineal laceration, any procedure like a cesarean section done under general anesthesia. All these are risk factors for getting postpartum hemorrhage. Now remember that in pregnant ladies, because of the volume expansion, shock appears very late unless they have lost a significant amount of blood. Pulse and blood pressure, they remain normal unless the blood loss exceeds 1000 ml. So visual estimation of the blood loss is very important because you will not get tachycardia or a fall in blood pressure unless the blood loss is more than 1000 ml. That is very important to remember. So, and also the visual blood, the estimation that is done, it is usually we tend to underestimate the blood loss. Now, how do you prevent postpartum hemorrhage? So let us see the various, like either in a vaginal birth or in the cesarean section, how you are going to prevent. What is the RCOG recommendation? So you have a vaginal delivery. The woman has no risk factors for PPH. To prevent PPH, you will give oxytocin 10 international units intramuscularly. That is enough to prevent a PPH. If she is undergoing a cesarean section, oxytocin is given 5 international units by slow IV injection. Okay. Remember, high dose of oxytocin versus the standard dose that is recommended by RCOG. There is no added benefit of giving very high dose of oxytocin. So stick with the standard dose of oxytocin. Whenever any woman is undergoing a vaginal birth and she has high risk of PPH, okay, so you can consider giving symptometrin. But remember, symptometrin you will not give if there is hypertension, if there is preeclampsia, and anyone with cardiac disease. Symptometrin is contraindicated, and this reduces the risk of minor PPH. Whenever there is a cesarean section, there is increased risk of PPH. Along with oxytocin, you can give tranexamic acid 0.5 to 1 gram. Uterine massage as a prophylaxis, it doesn't help to prevent PPH as prophylaxis. Okay. Now coming to the timing of cord clamping. So delayed cord clamping, more than 1 minute, it is good for the baby, but only if the mother and the baby, both of them are stable. Otherwise, you will not do delayed cord clamping. Carbetocin is another drug that might reduce the risk for need for additional uterotonics. But there is no clear reduction in the rate of PPH. So UK recommendation is first line, you will always give oxytocin 5 international units, slow IV for prevention of PPH. And carbetocin is another drug which can be used. With regards to misoprostol or carboprost, as for prophylactics, they are not superior to oxytocin. Oxytocin remains the first choice uterotonic for prevention of postpartum hemorrhage. Now, what is the initial resuscitation for women with PPH? If it is minor PPH, that means the blood loss is about 500 to 1000 and there is no shock, you can put in one IV cannula, 14 gauge IV cannula, take blood for grouping and screening, then FBC, coagulation profile and fibrinogen. Observations done every 15 minutes. Fluid that you will give is warmed crystalloid infusion. And you will alert the midwife in charge. You will alert the obstetric team and the anesthetic staff. But you will not call them immediately to the labor room. You will only alert them that there is someone with a minor PPH. As opposed to that, you have someone with a major PPH. That means there is the blood loss is more than 1000 ml and plus the woman is in shock. So you will keep her flat on the bed. You will keep her warm. You will put in 2 large bore IV cannulae, 14 gauge. You will start oxygen at 10 to 15 liters per minute. Blood, immediately 4 units of blood has to be cross-matched. You will send blood for FBC, coagulation profile, use and ease, and for liver function. Catheter has to be put to monitor the urine output also and to make sure that the uterus retracts. Continuously monitor her ECG, SpO2 and put her on the Meo's chart. And you will involve the team, the consultant obstetrician and the anesthetic in person, especially if the blood loss is more than 1500 ml and there is ongoing blood loss. At that time, you will call the team to the labor room. Fluids that you can give up to 3.5 liters of warm crystalloid till blood becomes available. Remember, no hydroxyethyl starch is given, no HES is given, because very severe risks of anaphylactic reactions. And whenever there is any PPH going on, there should be one person who is going to document everything, document all the events, okay? All the events that are happening, what are the fluids that are being given, what are the drugs that are given, what are the blood products given, and the observations of the patient. They have to be documented. So one person specifically is assigned to that. That person is called as the scribe. And you will also try to calculate what is the shock index. So the heart rate of the woman divided by the systolic blood pressure. It might identify women at risk of adverse outcomes. Of course, this is not something that is given in the guideline. It is not mentioned in Clean Top guideline. Now, remember, for management of PPH, the ladder is very important. Okay. So you will first, whenever there is atonic PPH, you will give uterotonics. Then mechanically, you will try to make the uterus contract. If that doesn't help, then only you will go ahead with surgical measures. So the drugs, the ladder is very important. Oxytocin 5 units as an IV bolus. Then infusion 40 units and 500 ml of normal saline at 125 ml per hour. And you can give ergometrin. Remember the contraindications. Now, if with these uterotonics, the PPH is not controlled, then you can give carboprost 250 micrograms every 15 minutes for a maximum of 8 doses. Do not give in patients with asthma. Carboprost also, remember, if the first 3 doses, you see that the PPH is not being controlled, it is better to shift to the OT for surgical management rather than wait. So hysterectomy is always done earlier rather than later. The next drug that is advocated after carboprost is misoprostol. So 800 micrograms per rectally if carboprost is contraindicated. So if patient is asthmatic, you cannot give carboprost, you can use misoprostol. If this also doesn't control the PPH, you can give tranexamic acid 1 gram intravenously. If not controlled, still then bimanual compression, examination under anesthesia to rule out trauma or retained tissue. If still not controlled, you can do Bakri balloon, that is intrauterine Bakri balloon, or shift her to the theater for a laparotomy and to put a brace suture, that means the B-Lynch compression suture. If still not controlled, you can do progressive uterine devascularization, uterine and internal iliac. If the patient is stable, if interventional radiology is available, you can do uterine artery embolization. And hysterectomy is the final step. But don't delay. Hysterectomy is done earlier rather than later. Don't wait for the patient to go into DIC and then do a hysterectomy. Now, what are the triggers for transfusion? Okay. So, fresh frozen plasma, you will give if coagulation profile is altered. So, if the APTT is more than 1.5 times of normal, or if you have given 4 packed red cells, according to the Green Top Guideline 52, or blood transfusion guideline, if you have given 6 units of packed red cells, then you will give 4 units of fresh frozen plasma, or you will give fresh frozen plasma in a dose of 12 to 15 ml per kg. And your aim should be that APTT, it should be either normal or it should be less than 1.5 times of your control. Fibrinogen, to replace fibrinogen, you will give cryoprecipitate. So in postpartum hemorrhage, if fibrinogen is less than 2 grams per liter, then cryoprecipitate is given. And your aim should be that fibrinogen levels should be more than 2 grams per liter in postpartum hemorrhage. If it is APH, fibrinogen should be more than 1.5 grams per liter. Platelets, you should aim to keep platelets more than 50 into 10 raised to 9. But don't wait for platelets to drop to 50. The trigger is if platelets become 75, then you will start your platelet transfusion. Hemoglobin, you should maintain at more than 80 grams per liter. So whenever hemoglobin is less than 80 grams, you will start giving packed red cells. To prevent the or reduce ongoing fibrinolysis, you can give tranexamic acid 1 gram intravenously within 3 hours of onset of postpartum hemorrhage. If you give later, it doesn't help. Now, recombinant factor 8A, something not given routinely. It is only given in cases of life-threatening hemorrhage. And you have to correct acidosis, you have to correct the hypothermia, you have to correct the thrombocytopenia. Only then you can give recombinant factor 8A. And cell salvage, if facilities are available to you, then whenever you think that there is a risk of having severe postpartum hemorrhage in these cases, like any patient who is having PAS, like placenta accreta spectrum, or any patient who is undergoing a hysterectomy because of PPH, in those cases, you can offer to do intraoperative cell salvage. So the targets that are there, we already saw. Hemoglobin should be more than 80, platelets more than 50 into 10 raised to 9. PT-APTT should be less than 1.5 times your control. Fibrinogen should be greater than 2 grams per liter. Now coming to secondary PPH. So bleeding occurring 24 hours to 12 weeks after delivery. Usually it is because of something remaining inside into the uterus. So these patients, they present with endometritis or retained products of conception. The initial assessment, you have to see what is the hemodynamic status of this patient, what is the amount of bleeding, whether there is fever or tenderness. You will immediately take a high vaginal swab. You will also take an endocervical swab. For secondary postpartum hemorrhage, usually they present with sepsis. So you will immediately start broad spectrum antibiotics. Clindamycin and gentamicin is one combination that is usually preferred because there is suspected endometritis. Alternatively, you can give coamoxiclav or you can give peptaz if the infection is very severe. And you will do a pelvic ultrasound because you want to have a look and see if there are any retained products in the uterus. But ultrasound is unreliable as the sole diagnostic tool. So even a clinical assessment will have to be done. And once you are sure that there are retained products of conception, under antibiotic guidance or under antibiotic cover, surgical evacuation is done by a experienced clinician. Remember, there is a very high risk of perforation of the postnatal uterus because the uterus has become very soft. And any woman who is RHD negative and she has had significant bleeding, please don't forget to give anti-D prophylaxis. So you have this 32-year-old woman who has had PPH. The blood loss is 1200 ml. 30 minutes after a vaginal delivery, uterus is atonic despite oxytocin 5 units, IV bolus, and also an oxytocin infusion. She has a history of asthma and gestational hypertension. What is the next most appropriate pharmacological agent? Hypertension, so you cannot give syntropentrin. There's asthma, you cannot give carboprost. So the only option that remains for here is misoprostol. Okay. So that is the correct option over here. Because all the other options, they are contraindicated. All right. Now coming to postpartum collapse. So the commonest causes, 7 main causes are there. Hemorrhage is the most common cause. Anyone having hemorrhage, there will be pallor, tachycardia, hypotension. The uterus is soft and atonic, or there could be even traumatic hemorrhage. Amniotic fluid embolism, sudden cardiovascular collapse, bronchospasm, there is hypoxia. Usually these women, they present immediately after the patient has delivered or during the process of delivery, intrapartum. Pulmonary embolism, it is sudden chest pain, dyspnea, tachycardia, hypoxia. Any woman with risk factors for VTE, always suspect a pulmonary embolism. Eclampsia, anyone with severe preeclampsia, hypertension, seizures, headache, visual disturbance, or proteinuria. Septic shock, so fever or hypothermia. tachycardia, hypotension, and altered mental state. Myocardial infarction. So it could be chest pain. You could have ECG changes, increase in the troponin levels. You have to differentiate this from peripartum cardiomyopathy. So remember all the risk factors for pericardiomyopathy, the ethnicity, age, history, family history of cardiomyopathy puts all these women at a high risk. Now, anaphylaxis due to any cause. So there could be urticaria, angioedema. She can present with bronchospasm and hypotension. So exposure to the allergenic agent, and she can present with anaphylaxis. Other rare causes of collapse are intracranial hemorrhage or drug overdose. This drug overdose, it could be even iatrogenic or other drugs, and sometimes even hyponatremia can lead to postpartum collapse, though it is a very rare cause. Now remember the 4 principles. So A, B, C, D, E. Always resuscitation, you will follow A, B, C, D, E principles. And remember the 4-minute rule. So if any woman, if you are not able to resuscitate her within 4 minutes, and if the pregnancy or if the uterus, you can palpate the uterus above the umbilicus, remember that you will do a perimortem CS for her. Now this perimortem CS, the rule is that you will deliver her within 4 minutes of the arrest. Why? Because it improves the maternal, your success of CPR is improved, and you are not bothered about this CS that you are doing. It is not for fetal survival. It is basically because it improves the maternal survival. So this perimortem CS, no need to transfer the patient to the operation theatre. You will do the CS wherever the collapse has occurred. In the passageway, in the labor room, wherever the collapse, in the A&E, wherever the woman has collapsed, you are not able to resuscitate her. You will do the perimortem CS there. Whenever you are doing the CS, CPR is continued. You will not stop CPR to do the perimortem CS. Chest compressions will continue. And after the uterus has been emptied or after the woman has delivered, it improves the effectiveness of CPR. One more thing you have to keep in your mind, that the neonatal team, it will always be there in attendance, because if it is like a 28-week uterus, the baby, you will hand it over to the neonatal team for further resuscitation. Now, amniotic fluid embolism is something which is quite rare, 2 per 100,000 deliveries in the UK. Mortality rate is very high. It improves with early recognition, usually intrapartum or at delivery or immediately in the postpartum period. The classic triad is of sudden cardiovascular collapse, DIC, and bronchospasm or hypoxia. Pathophysiology, there is amniotic fluid which is forced into the maternal circulation. It causes pulmonary capillary obstruction and it causes anaphylactic-like reaction, giving rise to DIC. And the death, the maternal mortality is usually because of DIC. Not all women are at a high risk. So maternal age more than 35, if there is placenta previa, induced labor, operative delivery, multiple pregnancy, polyhydramnios, or uterine rupture. All these are high risk factors for developing amniotic fluid embolism. There is no specific clinical test to diagnose it. It is usually a diagnosis of exclusion. So you have to rule out pulmonary embolism, you have to rule out anaphylaxis, you have to rule out myocardial infarction. The management is mainly supportive. So you will resuscitate her, you will give oxygen, fluids, vasopressors, blood products, and if it has happened antenatal, then you will do a perimortem CS. And it is mandatory that you will report it to UKOS. It is a mandatory reportable condition to UKOS. Now, how will you differentiate between all the causes of maternal collapse? Okay. So for amniotic fluid embolism, we already saw the classical triad that is there of collapse, DIC, bronchospasm, or hypoxia. It happens intrapartum. It could happen immediately post-delivery, And there is no preceding allergy. That is very important in amniotic fluid embolism. Now, pulmonary embolism, remember, any woman who is at a high risk of VTE, she suddenly develops dyspnea, tachycardia, hypoxia. There are signs of DVT. D-dimer, you will not lose anyway. CTPA is the one that is diagnostic. Anaphylaxis, so there is skin signs, urticaria, stridor is there, bronchospasm. There is always a clear, and you know that this woman is allergic to a particular substance and she is exposed to that. Immediately after that, if she develops all these signs and symptoms, it is anaphylaxis and she will respond immediately to adrenaline. Sepsis, there is fever or hypothermia. You have a source of infection. You will have raised lactate levels and she responds to fluids and antibiotics. So myocardial infarction, there is chest pain. On ECG, there will be ischemia. There will be raised troponin levels. If you do an echo, left ventricular function or ejection fraction is poor in patients with postpartum cardiomyopathy. Eclampsia, we already know. Eclampsia, massive hemorrhage. We know what all to see. And hyponatremia because of excessive doses of oxytocin. Okay, so the sodium levels are decreased and that can give rise to seizures or sometimes syndrome of inappropriate ADH or SIADH, syndrome of inappropriate antidiuretic hormone secretion. Let us see a few SBAs. So you have this 34-year-old gravida 3 para-2, she delivered at 36 weeks via a cesarean section for failure to progress. As the placenta is being delivered, she becomes dyspneic, hypotensive, and she has a seizure. Within 5 minutes, she develops marked oozing from IV sites and the surgical wound. Her CO2 drops. What is the most likely diagnosis? So DIC developing immediately. It can be nothing else other than amniotic fluid embolism. So see the time, it is typically intrapartum or immediately postpartum. The pulmonary, the TCO2 drops, that means the pulmonary vasculature, the CO2 drops there. And DIC, so, and bronchospasm, these are very typical of amniotic fluid embolism. Now coming to routine for postnatal care. So within 12 hours of birth in the hospital, you will observe the mother, do her obstetric examination. You will see her perineum, look out for if there is an excessive bleeding, whether she has been voiding freely or not. What is the mood of the mother? Rule out any psychiatric illnesses and see the baby, whether the baby is feeding well or not. And within 72 hours, you will do a newborn inspection and physical examination. Day 1 to 2, the community midwife will visit. Again, she will have a look at the mother, the blood loss, breasts, perineum, the mood of the mother, whether she's moving around or not. What about the feeding? Breastfeeding has been established or not? Whether the weight of the baby, it is stable, and whether the baby is developing jaundice or not. Day 5 is the time for heel prick for the baby and also a visit to the hospital. So the mother, you will screen for postnatal depression by the Woolley screen. For the baby, blood spot screen is done by heel prick and also the weight of the baby is checked. Day 10 to 14, you will discharge the mother from midwifery-led care to healthcare visitor. So the healthcare visitor will go at home. For the baby, you will continue to see feeding and also the weight. At 6 to 8 weeks, there will be a visit by the GP for the 6-week checkup and for the baby for NIPE and also for immunization for the baby. Immunizations will start at 6 weeks. If the mother is Rh negative and the baby is Rh positive, anti-D to be given to the mother within 72 hours of delivery. And MMR vaccine is nowadays given routinely in the postpartum period, post-delivery, and you will tell the mother to avoid pregnancy for 1 month. And VTE risk assessment again in the postpartum period. And if she is high risk for venous thromboembolism, you will give her a low molecular weight heparin for 6 weeks in the postnatal period. This is about the maternal 6-week checkup, what all you will do. So physical recovery, if she has had an episiotomy, you will see how the healing is there. Um, if she has undergone a cesarean section, you will have a look at the wound, whether the uterus is involuting well or not, bladder and bowel function, whether any complaints about that. You will have a look at her mental health also. Then breastfeeding, whether she's continuing breastfeeding or not, whether there is any difficulty, there is any pain with breastfeeding. You will discuss all the contraceptive options and what all methods can be started at 6 weeks. If she has had a hypertensive disorder, you will check up her blood pressure. And if she's on any medications, you will check whether you can taper off the medications or not. Cervical screening, if it is due, you will not do it at 6 weeks, you will do it 3 months in the postpartum period. And if during pregnancy a smear has been taken and if that smear is abnormal, the repeat smear is done at 12 weeks. Okay, at 6 weeks the smear is not done, it is done at 12 weeks. And at 6-week checkup, you will again see her VTE risk scoring. You will check for symptoms of DVT or pulmonary embolism, and you will check whether she has been compliant with the low molecular weight heparin that was offered to her. You will discuss about the future pregnancy planning. You will give her folic acid if she requires and preconception advice if she has any comorbidities. Now, postpartum contraception, this all, I'm sure it has all been discussed whenever FSRH has been done for you. So I'm not going to read this again. Let us come to some EMQs. Okay. So you have a patient with a confirmed missed miscarriage and she wants a medical management for that. So you will give her mifepristone 200 milligrams and you will give her misoprostol 800 micrograms 48 hours later. If it is an incomplete miscarriage and she wants a medical management, remember you will give her only miso, no mifepristone. Lady at 8 weeks of pregnancy with light bleeding, mean sac diameter is 22 millimeters, there is no fetal pole. You will rescan her 7 days later on before you come to a diagnosis. 7 weeks pregnancy, there is no fetal heart and CRL is 4 millimeters. Again, offer a rescan in 7 days. First line management of confirmed miscarriage. It is expectant management for 7 to 14 days. Any woman, no bleeding 48 hours after misoprostol, offer a clinical review. She might need a surgical management. Any woman undergoing medical management and UPT is positive after 3 weeks. So you will review her to make sure that it is not a molar pregnancy or an ectopic pregnancy. Any woman with bleeding, her pregnancy is less than 6 weeks, there is no pain, viable intrauterine pregnancy is unconfirmed. So always give her an expectant management and call her for a repeat UPT in 7 to 10 days. I think all of these we have discussed all these in detail. So these are basically the management options for methotrexate versus surgical versus expectant. So you have to know what are the indications to give methotrexate, what are the indications for surgery, and what are the indications for an expectant management of ectopic pregnancy. And then these are all again basically the revision slides for clauses of Abortion Act. We have discussed all these in detail. This is about postnatal mental health. We have discussed everything in detail, so I'm not reading them again. And this is the master recall trap sheet. All of this has been discussed in detail. It is being given here only for a revision. Okay. So these are some important points that you have to carry with you in the exam. Whenever the mean sac diameter is less than 25 ml or the CRL is less than 7 mm, you will do a rescan in 7 days. Do not come to a diagnosis immediately on one ultrasound. Anyone with missed miscarriage, give mifepristone as well as misoprostol. For incomplete, give only misoprostol. Whenever it is an ectopic pregnancy, beta HCG is less than 1500, you can offer methotrexate as first line management option. Hypertension is not a contraindication for methotrexate. Whenever you want to offer surgical management, salpingectomy is done by default unless the other tube is damaged. If other tube is damaged, you will do a salpingotomy. And for women with APLA and recurrent pregnancy loss, you will give aspirin and low molecular weight heparin starting the day the urine pregnancy test is positive and continue up to 34 weeks. Now coming to gestational trophoblastic disease, so whenever it is a complete mole, theoretically no anti-D needs to be given. Whenever the FIGO score is less than or equal to 6, you will give only single dose chemotherapy, that is methotrexate. If it is more than or equal to 7, you will give multi-drug, IMACO regime is given. For hyperemesis gravidarum, the picture or the biochemistry, there is hypokalemia and hyponatremia, and there is hyperchloremic. Remember, there is alkalosis initially. If it is severe hyperemesis gravidarum, you will get acidosis. Never ever treat the HCG, thyrotoxicosis. For pregnancy of unknown location, after 48 hours, if the rise in beta HCG is more than 63%, it is always likely to be an intrauterine pregnancy. For abortion, if you are terminating the pregnancy for clause A, B, or E, there is no upper limit. That means at any period of gestation, even if the pregnancy is more than 24 weeks, you can terminate the pregnancy. Whenever uterine perforations are there, 51% of the times they are caused due to a suction cannula. Now coming to sepsis. So for gas infections, the antibiotics of choice are piptaz and clindamycin. Whenever lactate levels are more than or equal to 2, it is an urgent referral, and lactate more than or 4, it is an indication to transfer to ICU. Valproate is always contraindicated in pregnancy and breastfeeding. If at all you want to give any SSRIs, you can give sertraline in breastfeeding. Remember, for PPH, carboprost is contraindicated in asthmatic patients. You will always try to do a Beeline suture if your Bakri balloon fails. And remember, for women with a maternal collapse, if CPR is not successful, you will start the perimortem CS at 4 minutes and finish it off within 5 minutes. So that is all for early pregnancy problems and postpartum problems. Thank you so much for a very patient hearing. I'm very sorry for the delay, but I hope the session was useful to you. Okay. And good luck to all of you. And I won't take more of your time. Bye-bye and take care. And thank you once again for attending.